All right. Good morning, everyone. This meeting's called to order. Our meetings are going to continue to be hybrid. Healthcare Authority staff will be on site, and board members and other attendees have the option of attending on site or via Zoom. For our Zoom attendees, our opening slide is information on how attendees can turn on the closed captioning subtitles. Do a roll call for board members today. John?
We're expecting him, but he's not here yet.
Okay. And he's coming in person. He's not going to do. Okay. Harry?
Yes, I'm here.
Michaela?
Present.
Tom?
Here.
Elliot?
Here.
Monica? You with us, Monica?
I'm present.
There you go. And Kurt?
I said here. Did you hear me? I'm sorry.
We got you. Appreciate that.
Yeah. Okay. Thank you.
And Michael Tunick from the AGO.
Good morning.
Good morning, sir. All right. And my name's Lou McDermott. I'm the Deputy Director here at the Healthcare Authority, and we'll be filling in for Sue Birch as chair today. With board members attending both in person and virtually, it would be helpful for the board to hold their questions until each presentation is done or when the presenter pauses and asks if there are questions. Board members attending virtually, we're going to watch in case you use your Zoom hand to indicate that you have a question. There are going to be a few resolutions scheduled for action today, so the public will have an opportunity to provide comments on those specific resolutions during normal procedure before board votes. The public will also have the ability to provide general comments at the end of the meeting during the public comment period. As a reminder, if the public has questions during staff presentation, the presenter's contact information is included at the end of their presentation. You're welcome to email them during the meeting to capture your question for response after the meeting. Dave, what do we got going on today?
Good morning, Chair McDermott and members of the board. First, I want to acknowledge a little bit of a different setup in the room for people. We've had a lot of critiques of our camera angles this board season, and TVW is here. I and the presenters usually end up having the backs of our heads, and so we've just had a lot of critiques. So we're reorienting a little bit. We'll have me and the presenters kind of at the end of our circuit of the oval. I know we've never traditionally had the director sit at the table with you, but it's all about camera angles. So appreciate your grace in that and our ability to be more responsive to public suggestions related to how our meetings appear on TVW as well as the record after the fact. So just wanted to acknowledge that briefly. One more housekeeping thing before I go through the agenda. If you need the restrooms, they're down the hall to the right. If you see the elevators, then you need to turn left. And if we have an emergency and need to leave, we go out to the visitor parking lot out here to my left. So today we have the action scheduled for the board on the 2024 Medicare premium resolutions, the Medicare premiums that were presented by Molly Christie at the last board meeting on June 29th. And then we will move into the space of our non-Medicare premiums for 2023. And we'll start with the presentation by Beth Heston reviewing changes that are embodied within the premiums that will be presented then by Tanya Duhl from our finance team. We know that there are some questions by members of the public who are just seeing the rates for the first time. We've kept you apprised throughout the board season about the negotiation process with all of the carriers for both Medicare and non-Medicare. And we know that there are a lot of people who have a lot of concerns related to some of the premium increases that will be presented by Tanya. And so we have some folks from Kaiser Permanente here to give some insights about their rate proposals that resulted in the premiums you're seeing, as well as to answer some of your questions. Then we'll move into some presentations about our procurement process. John Parton talked about the benefit cycles last time, and now we're going to have someone, Shauna Lang from our procurements and monitoring and contract management section, talk about specific procurements. And we're really just trying to help people understand the flow of work and the amount of time that it takes and the steps that are necessary to go from an idea to implementation, whether it's a full benefit plan or a change within a benefit. And so that's really kind of the theme you're seeing lately. We've noticed surfaced a lot of questions over the last couple of months, both from the public and board members, that we thought it would be good to go through different steps of that and talk about it, the same topic from a couple of different angles. So Shauna will be here to talk about that. And then we are working on implementing a new vendor for our Smart Health program, and we have Kristen who will be joining us to talk a little bit about how the implementation of that is going. And then, as strange as it may seem, we're nearing the very end of our board season, and so it's already time to get your calendars ready for 2024. So I'll go over the schedule for next year. And that's what we have today, Chair.
Questions from the board? All right. Seeing none, first up, we're going to be voting on the meeting minutes from our last board meeting on June 29th. They're behind tab number 3. Are there any comments from the board? Seeing none, do I have a motion to approve the minutes as written?
So move.
Is there a second?
Second.
All in favor say aye.
Aye.
Any opposed? All right, the June 29th, 2023 minutes are approved as written. Thank you. Next up is our 2024 Medicare premiums. Molly Christie, fiscal analyst in the Financial Services Division, is joining us to present for a board vote the 2024 Medicare premiums that were introduced during our last meeting. After Molly reviews each of the resolutions with us, I'm going to ask for a motion to adopt. A second, I'm going to invite for public comment on the resolution, and then I'm going to ask for discussion from the board until we're ready for a vote. We'll ask for public comment specific to each resolution one at a time. Please make sure that you raise your hand to give comments on the resolution related to the plan your comments are about. So comments on the Kaiser plans during the Kaiser resolution, comments on the United plan during the United resolution, etc. Her materials behind tab number 4. Molly, welcome.
Thank you. So I'm Molly Christie, for the record, with our PEBB finance unit. And today I'm returning to present the 2024 Medicare premium resolutions for action by the board. So I will move right in. The next section presents the same rates that I previewed at the June 29th board meeting. I brought back a few slides here that show how we calculate the monthly retiree premium. So I'll walk through those pretty quickly. As a reminder, the monthly single subscriber premiums presented today and approved by the PEB board represent the total plan bid rate minus the Medicare explicit subsidy. So the bid rate is the total monthly premium, or the price to enroll in a plan on a per member monthly basis. And the premium is the amount that retirees actually pay per month. So that's the total bid rate minus the Medicare explicit subsidy. I do want to mention a little confusing terminology that we use. When we talk about the subsidy, we say $183 or 50% of premium, whichever is less. And I just told you that retiree premium is what retirees pay after the subsidy. So I understand that's confusing. When we talk about the subsidy and we say premium, we really mean the bid rate. So it's the maximum amount, which is set by the legislature, or $183, or 50% of the bid rate, whichever is less. We use those terms interchangeably when we talk about the subsidy. So on the next slide, I have a couple examples of how this works. So Plan 1 has a bid rate of $400 and Plan 2 has a bid rate of $200. If we start with Plan 1, we see that it receives the maximum subsidy amount of $183 because this is less than 50% of the bid rate, which is $200. So if you take $400 minus $183, that gets you your monthly single subscriber retiree premium of $217. Now, if we move to Plan 2, this plan receives a lower subsidy amount because it's starting with a much lower bid rate. So in this case, 50% of the bid rate is actually $100, which is less than the cap of $183 for the subsidy. So you end up with a subsidy of $100. That also happens to be 50% of the plan bid rate. So you can think about this two different ways. The retiree premium is 50% of the bid rate, or the retiree premium is the bid rate minus the subsidy, which is 50%, which gets you to $100. All right, moving into the rates. Again, this table shows the 2024 proposed single subscriber Medicare retiree premiums after the explicit subsidy, as well as the percentage and dollar change compared to 2023. I went through in quite a bit of detail in the last presentation, some of the background behind these rates, how they were developed, why we're seeing increases across all of the plans. So that is included in my previous presentation if anyone wants to go back and look at that. We've also included some slides in the appendix to this presentation that also have things like the benefit changes that are built into these rates for the fully insured plans. Another note is that the UMP Classic Medicare premium does have the change to hearing aids included. So that was a $6 reduction to the 2024 proposed premiums, and that's already built into the rate that you see today. Moving on.
Molly, this is Dave. I just want to highlight one other change that is embedded within the rates because we've had quite a bit of public dialogue about it. The Kaiser First Fill program is unwound, meaning that the requirement to use mail order drugs after the first fill would be unwound and would no longer be a requirement come 2024. That is embedded within the Kaiser Medicare Advantage rates as well. So just wanted to draw specific attention to that one because of the amount of public comment and dialogue we've had about that particular benefit design aspect.
Thank you. That's a good call out. This slide shows the same premium costs. This is just annualized. So we take the monthly premium for a single subscriber and multiply it by 12. And so you can see as a single subscriber what a retiree would pay on an annual basis. And then the next slide shows the monthly single subscriber premium that I just presented, as well as the subscriber plus spouse or state registered domestic partner rate. So this rate is for two members who are Medicare eligible, and it's simply twice the single subscriber premium. The only difference is that we only charge the administrative fee once per account. So it's not exactly twice the single subscriber premium because we're not double charging that HCA administrative fee. Okay. And I am moving pretty quickly, so please stop me if anyone has questions. This table has the value of the Medicare subsidy by plan, which I described as a function of the total bid rate. The composite rate here is the total bid rate plus the HCA administrative fee. So it's not very different from what you've seen. It's just a few dollars off from the total bid rate. And you can see that 3 plans have reached the proposed 2024 subsidy cap of $183. And these are Kaiser Northwest Senior Advantage, UMP Classic Medicare, and then Premera Medicare Supplement Plan F for beneficiaries who are enrolled due to disability. All right, and then next are the premium resolutions for action by the board. Board members will be asked to adopt the resolution for the carrier, not the individual plan. This adopts premiums for all of the PEB Medicare plans offered by that carrier, as well as the underlying benefit design. And again, the details on that benefit design and any of those changes for 2024 are included in the appendix for reference. Okay, so I'll need, this is the first time I've done this, so I'll need a little bit of help with this transition here. Chair McDermott, do I move this over to you now, transition to you to read through these resolutions?
I think you just did. So okay. I got it. Thank you, Molly.
Thank you.
Are there any questions for Molly? All right, here we go. We're going to vote on resolution PEB 2023-06 Medicare explicit subsidy. Resolve the PEB board endorses the calendar year 2024 monthly Medicare explicit subsidy of $183 or 50% of premium, whichever is less. Is there a motion to adopt?
So move.
Is there a second?
Second.
Are there any comments from the audience? Seeing none. Are there any comments from the board? Seeing none. It's going to be a roll call vote. Starting with Harry.
Yes.
Michaela.
Yes.
Tom.
Yes.
Elliot.
Yes.
Monica.
Yes. Yes.
Kurt.
Yes. Yes.
And Lou, yes. Resolution PEB 2023-06 passes. All right. John, welcome.
I'm sorry about that. I
You're
was
okay.
thinking it's 9:30 and
It's all right.
I got a little tied up.
You've heard some of the preliminary stuff that we go through, so it's same stuff. We're just starting the voting process.
Chairman Durden, I'm just impressed everybody got Wednesday right. The shift to Wednesday, I was
That's true.
very worried about.
He was
So
very
I'm
concerned
very
that
glad
we were going
everybody
to have
made it to the right day.
an empty house.
Oh no, they just would have joined the sub meeting.
Well, there's that.
Jessica was helpful in setting us up for today.
Awesome.
you.
And then back to Molly.
Yeah, so on the next slide, I do have just a quick clarification. We updated resolutions 7 through 11 to include reference to 2024 in the titles. So for instance, on the next resolution, you'll see Kaiser Washington Medicare 2024 premiums in the subtitle. This was the only change compared to the proposed resolutions presented on the 29th. I just wanted to call that out before we move on. So I will transition back to you, Chair McDermott.
All right. Any concerns from the board on that change? All right. We're going to vote on resolution PEB 2023-07, Kaiser Northwest Medicare 2024 premiums. Resolved that the PEB board endorses the Kaiser Foundation Health Plan of Northwest Medicare Plan premiums. Is there a motion to adopt?
Yes, I'll make the motion.
Is there a second?
Second.
Are there any comments from the audience? Nope. Any comments from the board? Nope. This is going to be a roll call vote. Harry,
Yes.
Michaela,
Yes.
Tom,
Yes.
Elliot,
Yes.
Monica,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution PEB 2023-07 passes. Molly.
So the next resolution is for the Kaiser Washington Medicare 2024 premiums. And do I read through these? I'm sorry. Do I read through these or do you?
Fine. I just want to make sure that if you had any material you want to go over, no?
No, nothing here. I'm pretty much done. So we'll just run through these.
It's pretty much done. Okay. Vote. Yeah. Vote resolution PEB 2023-08, Kaiser Washington Medicare 2024 premiums. Resolved that the PEB board endorses the Kaiser Foundation Health Plan of Washington Medicare Plan premiums. Is there a motion to adopt?
So moved.
Is there a second?
Second.
Any comments from the audience? Seeing none. Any comments from the board? Seeing none, this is going to be another roll call vote, starting with Harry.
Yes.
Michaela,
Yes.
Tom,
Yes.
Elliot,
Yes.
Monica,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution PEB 2023-08 passes. Next resolution. Resolution PEB 2023-09, United Healthcare Medicare 2024 premiums. Resolved that the PEB board endorses the United Healthcare Medicare Plan premiums. Is there a motion to adopt?
So move.
Second.
Second.
Any comments from the audience? Seeing none. Any comments from the board? Roll call vote starting with Harry.
Yes.
Michaela,
Yes.
Tom,
Yes.
Elliot,
Yes.
Monica,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution PEB 2023-09 passes. Next resolution. Resolution PEB 2023-10 Primera Medicare 2024 premiums. Resolved, the PEB board endorses the Primera Medicare supplemental plan premiums. Is there a motion to adopt?
So moved.
Is there a second?
Second.
Any comments from the audience? Seeing none. Any comments from the board? Voting starting with Harry.
Yes.
Michaela,
Yes.
Tom,
Yes.
Elliot,
Yes.
Monica,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution PEB 2023-10 passes. Next resolution. Resolution PEB 2023-11 UMP Classic Medicare 2024 premiums. Resolved, the PEB board endorses the Uniform Medical Plan Classic Medicare Plan premiums. Motion to adopt.
So move.
Is there a second?
Second.
Any comments from the audience? Seeing none? Any? Oh, I'm sorry.
I would apologize. Suspect there's
Yes. Who? Amy Fortier?
Yes, I'm here.
You have some
May
comments?
I go ahead?
Yes, ma'am.
Good morning, Chair McDermott and members of the board. My name is Amy Fortier. I live in Sequim, where we are experiencing some challenges, especially for our hospital here. And I'm seeing that these challenges are exhibited in this outrageous 22% increase for the Uniform Healthcare Plan. This is far beyond the reach of the pension increases that retirees are receiving, which are 3%. I would like to urge the board to maintain the UMP Medicare premium at the 2023 rate rather than increasing it at this time. I think there's a need to receive greater input from the legislature, plan subscribers, and potential providers who can all work within the structure of self-insurance provisions. This may mean reaching out for new partnerships to private industry who are also self-insured and looking at some new things, innovations rather than historical partnerships. I also urge the Healthcare Authority and the board to formulate reasonably priced choices to be offered for 2025 that include public plans and discourage further private plans. There should be two-way input loops between Healthcare Authority staff and subscribers that allow for recommendations, analysis, and impact analysis that is meaningful and includes responsive service levels and something that is economically feasible for retirees to pay at this time. Further privatization should be discouraged. Please vote no on this 2024 UMP resolution. Thank you for your time.
Thank you, Amy. Do we have others? Seeing no others, any comments from the board? Seeing none, this will be a roll call vote, starting with Harry.
Yes.
Michaela,
Yes.
Tom,
Yes.
Elliot,
Yes.
Monica,
Yes.
Kurt,
Yes.
and Lou, yes. Resolution PEB 2023-11 passes. All right, next up, we have the sorry, sir.
Chair, I just want to acknowledge, I know that that's a difficult vote for a lot of board members. No one wants to be in the position of presenting large increases like this, and I know that many of you don't want to have to vote for increases like that proposed for UMP Classic Medicare and any of the plans. One of the challenges that does exist, though, is, and we've had this conversation over the board years, is unless there is an affirmative step taken by the board, the plan doesn't exist. The status quo is there is no plan until 2024 unless the vote that you just took existed. There's, simply put, until 10 minutes ago, no plans existed in the Medicare portfolio for 2024. We reboot and you have to affirmatively authorize a plan year over year. So I know that is a difficult vote to take, and I just wanted to remind and put that on the record and provide people that context of it does require an affirmative step by the board each year to authorize a plan. The plan does not exist in perpetuity without continual action year over year by the board. So just wanted to provide that and acknowledge the difficulty of that vote.
You know, Dave, I also wanted mostly for the public, but I know it sounds pretty callous when we vote like that. We just go through the vote and everyone does it. And I'd like to just remind people that this didn't just happen this morning. This has been a multi-month event. There have been a lot of questions asked and answered, especially in executive session. There has been displeasure voiced. There has been prodding. Why is it like this? What can we do for the future? So just know that there is a lot of discussion that occurs to get to this point. Monica?
Thank you. And I just want to reiterate one point as a healthcare provider who is on the board. That was a very difficult vote. And I appreciate the board and the staff acknowledging that. I also would like to further contextualize by saying that, healthcare is currently in a huge transition. And as we continue to have these discussions, I hope that the public appreciates the fact that we hear you, and it is not that, we have not voiced our opinions about these premiums and these rates because, yes, we hear you. That said, folks will not have an opportunity to participate in open enrollment if we don't actually have plans for them to be able to engage around. So thank you for holding the complexity of and the tension of this process.
Thank you, Monica. Anyone else? Terry?
Yeah, I want to second what Monica said, but also we've heard some ideas on potential for 2025, which I understand would be quite a reach, but I think it's something that the board and the staff, if we work hard together, regardless of how many meetings are required, if it's feasible, possible at all to do something meaningful in that time frame, that hurried time frame, then I would like to see us make every effort to accomplish that. Thank you.
Appreciate that. Others? Yes, sir. John?
I know how much time and effort the staff has put in to negotiating and trying to maximize the value. These rates really certainly are not pleasant. They're not easy to accept. But I really do think coming back towards next year, that we have a lot of work to do. And looking forward to joining all of you and making sure that we can, again, try to get the best possible rate for our customers. And at the same time, provide service that covers everyone in the state.
Appreciate that. Others? All right. Thank you. Medicare update. Ellen Wolfhagen, Senior Account Manager in the Employees and Retirees Benefit Division, is going to be providing a Medicare update to us on a few questions that have been asked earlier in the board season. Materials behind tab number 5. Ellen, welcome.
Thank you. Good morning, Chair McDermott, members of the board. For the record, my name is Ellen Wolfhagen. Today's presentation topics, next slide, are a follow-up to last board meeting where there was a question asked. I'm going to talk a little bit about ACO REACH and then give an overview of the UHC appeals processes. Next slide. Question was asked about COVID-19 vaccines and how they're covered under Medicare. COVID-19 vaccines are covered as preventive under Medicare Part B, like boy. They are not Part D drugs. They are considered medical. They're covered as a medical expense also under the Uniform Medical Plan. And just a reminder, under UMP, medical expenses are paid by Medicare first. And there are no copays or deductibles for the vaccine in any plan because it is considered preventive. Next slide. So accountable care organizations, ACO and ACO REACH, is a topic that has come up a number of times in different venues. And I started to do a little bit of digging. I'm going to be the first to say this is minor digging, not major digging. So please bear with me on this. An ACO is an accountable care organization. It's a term of art used by the Center for Medicare and Medicaid Services, CMS. It has to do with the alternative payment models that are part of the cost containment process that CMS engages with in different areas. These arrangements are not part of the negotiation or administration of the PEB Medicare plans. They have nothing to do with the PEB Medicare plans. Generally speaking, an ACO is a group of providers or facilities or facilities who work together to improve the quality and experience of care. So it's a little bit like a managed care organization. Next slide, please. The Medicare website provides a list of the providers and whether they're part of an ACO, and I've provided the link to that website. Right now, I know of 2 ACOs in Washington State, Peace Health and Northwest Momentum Health Partners. Members can use a provider in an ACO or choose to use a different provider as long as they accept Medicare, and there's no difference in what they would pay in their cost share. Next slide, please. This is the quote from the Medicare.gov website. An ACO won't limit your choice of healthcare providers. It is not a Medicare Advantage plan, HMO plan, or an insurance plan of any kind. Only people with original Medicare can be assigned to an ACO. I just want to make a note that sometimes we refer to original Medicare as traditional Medicare. They're the same thing. That means Medicare Part A and Medicare Part B, like boy. If your doctor or other provider is part of an ACO, you still have the right to visit any doctor, hospital, or other provider that accepts Medicare at any time, and your original Medicare benefits will not change. I hope that that provides some assurance to people who've asked questions about ACO REACH, and if there are further questions that arise, I'm happy to research further. I'd like to give an overview on United Healthcare Appeals, and I do want to set a little bit of context here. As a reminder, the plan started in 2021, and the enrollment increase between plan year 2021 and 2022 was about 155%. At the end of 2021, in both United Healthcare plans, that's PEB Complete and PEB Balance, we get all of this information combined for both plans. There were 3,906 enrollees. In 2022, at the end of the year, there were 9,944. Given that increase, that's part of the drive between the appeals numbers going up. Another piece of context is that because the United Healthcare plans are Medicare Advantage plans, they are bound by the Medicare timeline for resolving initial appeals. If they do not receive the required information within 72 hours, the plan has no choice but to issue a denial. That denial, in most cases, is overcome by the provider and/or member sending in more information to address the issues at hand. Most of the appeals, as you'll see in the next slide, have, especially for medical, are based on billing issues, and that has to do with providers either not providing a complete billing history, or not coding correctly, or not having all of the information. Go back a slide, please. Pharmacy appeals are a little bit different. Pharmacy has a lot of prior authorizations. Again, because these plans are Medicare Advantage plans, and because the pharmacy is covered as a Part D pharmacy plan, it is under the rubric of the Medicare timelines. Information has to be received within 72 hours, or the plan has to issue an initial denial. For prior authorizations required, most often that means that the provider did not turn in the required prior authorization material in a timely fashion. It should be noted that, again, most of these initial situations get resolved through subsequent turning in of documentation. Next slide, please. These are the top reasons in 2022 for pharmacy. Again, you can see prior authorization was the most common reason for it. There were questions about formulary that would be either tiered questions or a plan not being covered. Plan dissatisfaction was somewhat high. It was about 12% of all the appeals that were received. And I do want to note that in 2022, there was a switch in how the pharmacy copays were done, and that created some of the plan dissatisfaction. We also had a number of people who had switched from either uniform medical plan, classic Medicare, or the Kaiser plans, and the pharmacy is handled differently because it's now a Part D pharmacy plan as opposed to creditable drug coverage, which is a little more lenient in how it approaches, for example, prior authorization. Tier exception, I think there was one appeal on that. Non-formulary exception, there was one appeal on that. So there are very, very limited appeals on, gee, the drug that I need is not covered at all. And I'd like people to keep that in mind. Next slide, please. For medical appeals, again, the top issue is clearly billing issues. And again, unfortunately, most of that has to do with providers not turning in information in a timely fashion. Prior authorization was also an issue. And again, in the transition from one plan to a new medical plan, if the member had prior authorization previously under their other medical plan, they need to renew it or upgrade it, get it done under the new plan. A lot of people and providers were confused about that requirement, and that's part of what drives the appeal numbers. The next most common appeal reason was exceeding the visit limit. So we have a couple of benefits that have a limitation. For example, 30 massage visits a year. If you have your 31st massage visit, then you're going to exceed your limit and be denied. Other is just a reason that didn't fit into any of the other categories. And then the last reason was the services were not actually covered by the plan at all. And with that, I am open to any questions.
Oh, I see questions. We'll start with John.
Ellen, I noticed that the number of appeals that were successful went down significantly between 2021 and 2022, medical appeals.
Can we put that slide? Can we put that slide back up?
I know it's not a large sample, but the appeals were 100% successful in 2021 and only about 2/3 successful in 2022. Is that a trend, or is it too early to tell?
It's too early to tell, and some of it has to do with the kinds of appeals that they are. Most of the successes were based on information that was needed being turned in. So it's appealed within, let's say, they had an initial denial within 72 hours. If they appealed within a week, then it could take more time for the provider to get information in. But if the information came in the next week or so, then it was granted. And so that's part of the situation. There are, I would say, almost all of the granted appeals are based on documentation being received.
So it doesn't seem to be a trend in terms of turning down certain
No,
services.
there's no identifiable trend of this kind of service or that kind of, even in pharmacy, it's not a specific drug that we can identify.
And the reason I'm asking is, as you obviously know, there's a lot of criticism of
Yes.
managed care
Yes.
through Medicare Advantage, and I just wanted to see if, and I've heard complaints outside of PEB about that throughout the country.
Right, and there's a difference between the appeal rates and the prior authorization denials on the commercial market and what we have in PEB. And I will say it's much tighter in PEB. We have far fewer denials, and there's more of an affirmative action on the part of United to make sure that people get the documentation that they need and understand. Thank you.
Elliot?
I'm sorry, but I'm still not clear on the Medicare requirement for appeals. So what you're saying is there's a very tight timeline in which to submit documents. And let's say I'm a provider, I'm not used to this. If someone switches from UMP to UHC,
Well, in fact, since Medicare pays primary under UMP, the provider should be aware of the requirements. The problem is that, say you had been on UMP for 5 years, right? Your provider may have done the prior authorization in previous years and had forgotten that they needed to do a prior authorization again. Or you got a prior authorization, let's say in June of last year, then you switched plans. And the provider may not be aware that they had to redo the prior authorization. And I will also say that in my experience as I follow through escalations on some of these, sometimes it's a problem between the billing office and the provider. The provider knows what's going on. The billing office sometimes is a little slow in getting all the documentation.
The other thing I'm not clear on is what is that Medicare rule that they have to follow? That wasn't clear to me.
So the Medicare rule is initial decisions have to be made within 72 hours with all of the documentation in hand, if you will,
Initial decisions
by the plan,
by the plan.
yes.
Okay.
Michaela?
So this is potentially a two-part question. So with regards to the denials that are based off of the billing issues, who is responsible for the appeal? Is it the healthcare provider or the enrollee?
Either the provider or the member can initiate the appeal.
Okay, and then with regards to kind of if the onus or if it could fall on the enrollee, is there any understanding or data that helps us know if it has an impact on people with like limited English proficiency or other types of language access barriers, trying to figure out how to navigate that, knowing that this is kind of an administrative 72-hour requirement, then putting the onus on somebody else, having to figure out how to navigate that to overcome that appeal?
I do not have that, Michaela, but I'm happy to ask further questions and find out more about it. That's a great question, thank you.
Other questions or comments from the board? Ellen, thank you so much. Dave,
Thank
we're
you.
scheduled for a break. Do we want to keep going? We're ahead of schedule, or do you want to? How do folks feel? Do you want to?
Well, I would like to move so that I can see this.
Okay, why don't we take a 10-minute break? You can move, and we'll all be good. All right, back at 5 till.
Okay, with
We back live. Excellent. Next up is Beth Heston, Procurement Manager for the Employee and Retiree Benefits Division, is going to go over some benefit changes for the 2024 non-Medicare PEB plans. They're included in the rates and premiums Tanya is going to present later today. Materials behind tab number 6. Beth, welcome.
Thank you. Good morning, Chair McDermott. I'm Beth Heston and members of the board. I am the PEB procurement manager, and I also am an account manager for Kaiser Permanente. We are talking today about the rate changes, and I want to touch briefly on the annual renewal timeline. Dave mentioned it earlier. In February, early March, it was late February this year, the 27th, we released the RFR, which is the request for renewal. And actually on April 10th, the responses came back from our partner carriers. Normally in June, we finalize the rate negotiations with those carriers and speak with the board about what's going on. And then in July, we publicly present the rates to the board, and there's a vote, of course, on rate resolutions. Next slide. Today I'm discussing the benefit changes that have been decided upon, and we're going to start with Kaiser Northwest. Kaiser Northwest operates in Clark and Cowlitz County in southern Washington, and it also is in selected counties in Oregon. The first changes that we have for that for those plans revolve around state legislative mandates. The House bill on hearing instruments that provides coverage at no less than $3,000 per year every 36 months. Senate Bill 5242, which prohibits cost sharing for pregnancy terminations. and Senate Bill 5396, which eliminates cost shares for diagnostic and supplemental breast exams, specifically the mammograms around those. Okay. We also have federally mandated changes this year, and we've discussed them, but I wanted to remind everyone, the IRS announced a required increase to the deductibles on high deductible health plans, also known as consumer-directed health plans, CDHPs. Kaiser Northwest will be increasing the deductible on their CDHP from $1,500 to $1,600. Next slide. Now we move on to Kaiser Washington, which is in 17 counties around the state. Next slide. They are making the same changes for hearing instruments, cost share for pregnancy termination, diagnostic and supplemental breast exams, and the federally mandated increase to the CDHP. Other changes that are proposed under Kaiser Washington have been made as an effort to reduce premiums and further alignment amongst the PEB plans. So they'll be aligning more with our UMP offering. First of those is a change to chiropractic manipulative services acupuncture massage. You will recall that last year there was an increase in the number of visits, and so the visits have increased on Kaiser Washington as well to 24 visits per year for each service category. There also will be, Molly spoke about it earlier, about the untangling of first fill on the Medicare original plan. We will also be untangling first fill from the regular employee plans for Kaiser Washington. They are going to add a $10 copay for telehealth, which aligns with the UMP's benefit. And they will be adding a $20 copay for primary care to the Sound Choice plan, again, aligning with the other PEB plans.
Beth, I'm just going to jump in for a moment. It's one of these things is kind of a chicken and the egg. We're talking about the benefit changes, and then Tanya's going to come up and talk about the premiums and rates, and it's kind of like they're kind of hand in glove, really. And so I might pick up this breadcrumb I'm about to drop in a few minutes as well, but just wanted to highlight again that some of these changes represent increases at the point of service when a member goes and has an appointment. For example, a telehealth appointment, or in the context of Sound Choice here, a primary care office appointment. One of the things that's important for the public who's just seen the rates for the first time almost 24 hours ago, that they haven't been on the same journey that the agency and the board have been in executive session about the past couple of months is, there are substantial rate increases that are in the non-Medicare portfolio. We know that there's going to be a lot of members who are going to be really challenged to think about what plan is the right plan for them going forward and balance both their desire for specific providers that they may have long-term relationships, their loyalty or preference for a specific health system, as well as the cost of that from a premium standpoint, as well as those costs when they have a service that they receive. One of the things that is a hallmark of these changes is if a member were to switch plans, for example, if somebody left a Kaiser plan and went to the Uniform Medical Plan, they would be experiencing an out-of-pocket expense for a telehealth visit already. And so several of these changes, while they represent a shift from kind of predictable premium cost to point of service, when you get a service you have an out-of-pocket expense, it is to help people have a better ease at comparing the experience they would have when they are going to be naturally in this position of looking at and assessing their health plans. So that was some of the logic that I just wanted to help people in the public understand some of these. It's like, oh, well, costs are going up and you're going to charge me a copay. Well, the premiums would have been even higher without these types of changes, but it helps our thought process here at the agency is to help members have a better opportunity to really understand the impacts whenever they're going to be assessing their plan choices this fall. And so some of these represent, quite frankly, parts of the benefit design that were richer in the Kaiser Washington non-Medicare plans compared to other parts of the portfolio. And so helping align that in the portfolio may help reduce some confusion as people are trying to understand the choices they have. So just wanted to provide that piece. And I do want to say that Beth described these as all, I forget the word used. I just wanted to highlight that there is actually removing the first fill program did actually does have a cost increase in the premiums. It is a I don't want people to think that doesn't come at a cost, and it is all baked into all of the changes. But I did want to say that that does have an impact on premiums, removing that. But again, for the reasons that were described earlier, we know that there has been a lot of public dialogue about that particular benefit design change, and so it is again incorporated into these changes for 2024. And then the last thing, I've learned a lot this year that when we say non-Medicare, a lot of people go, "What do you mean by non-Medicare?" When we say non-Medicare, that's really parentheses, non-Medicare retirees and employees. We use that phrase to cover both the employee and non-Medicare retiree population. They're together in the same risk pool, which is called the non-Medicare risk pool. That's why we call these the non-Medicare rates. But anytime somebody's describing non-Medicare, they really mean non-Medicare retiree and employees. And if they say employees, that comes with also non-Medicare retirees. And if they say non-Medicare retirees, they also mean employees. So I just wanted to make sure that those are all interchangeable, synonymous terms in what they define as, because that's actually come up quite a bit this last year, more than it has in the last 9 years that I've been with the program. So back to you, Beth.
Okay, we're moving on now to uniform medical plan, and the next slide, please. The same state, or two of the same legislative mandates from the state around hearing aids and around, which was presented in the board resolution 2023-03, and then the Senate Bill 5242 prohibiting cost shares for pregnancy termination apply to the uniform medical plan. However, the change to diagnostic and supplemental breast exams cost sharing does not apply. Because of the way the statute was written, it did not include a change to our specific plan. So that will not be implemented. Federal changes we've spoken about, you've already voted on the increase to the UMP CHP. Next slide. For dental plans.
Oh, Beth, one more
sorry.
thing. I realized this morning as I was just doing my final checks that we'll add this as a slide next meeting, but I want to say it today because it is an important change that somehow as we were preparing, we just missed making the slide for it. So I apologize for this. There is a service area change for UMP Plus. So that's the UW or Puget Sound High Value Network Accountable Care Program. So the changes are only within the UW UMP Plus plan. It's both the current service area would lose Kitsap County but gain Benton and Franklin County. So I want to say in Kitsap County we currently have both of the UMP Plus plans, High Value Network and UW. High Value Network will remain in Kitsap County, and so there is still would be an opportunity for individuals. There are about 268 members that are in the UMP UW Accountable Care Program, and they would be able to transition to all the other plans that are offered in Kitsap County. So there is a service area reduction for that plan of Kitsap County, but an expansion of Benton and Franklin County. So we'll get some maps, slide on that for next week to make sure that you have that in your materials and can see it and the public can understand that. My apologies for us putting that in the slide deck. I think it just goes to testament as to how many things are moving this year for changes within the portfolio and things to report to you on. So my apologies again for that not being there. It's an expansion to Benton and Franklin County and a retraction of Kitsap County for just UMP plus UW Accountable Care. And we really appreciate our partnership with High Value Network and UW about looking at opportunities to expand service areas, especially to our Eastern Washington members. And so I'm really excited that we've been able to find an expansion opportunity.
Thank you, Dave. And now we'll turn to dental plans. And the upshot here is nothing has changed for benefits. You might remember there's been a lot of discussion about dental changes, and Ellen has presented quite extensively on dental changes. But the decision package that was put forward, final operating budget did not increase any benefits. There were no increases for PEB. So, any questions about anything?
Michaela?
Yeah, thank you, Beth. So with regards, I just want to make sure I heard you right. Are you saying that cost sharing would still be allowed for UMP with regards to breast exams?
Yes.
Okay. And then second one, with regards to kind of the change in service area for UW, how will folks, how is outreach going to be done to those folks who are impacted?
Yeah, I can take that one, Michaela. We've had expansions and retractions and even flips. There was a point where Spokane County flipped from one network to the other. And so we have quite a bit of experience with individual outreach attempts. The population has been just about the right size that we've been able to actually do very tailored, down to the point where in one instance we had a project staff member who individually attempted phone calls to 400 people. So we anticipate that we'll be able to activate some of those things that we used before with specific outreach to those individuals.
Other questions or comments? Seeing none? Thank you, Beth. Appreciate it. Next up, Tanya Dool, PEBB Finance Manager in the Financial Services Division, is joining us to go over the 2024 non-Medicare premiums with us today, and also introducing the related resolutions. No action is needed for today on these resolutions. Materials behind tab number 7, and joining her, I see Megan Atkinson, our CFO. Welcome.
All right, thanks, Chair McDermott and members of the board. For the record, my name is Tanya Dool. I am the PEBB Finance Manager, and I am joined by...
Good afternoon, good morning, actually, members of the board, Chair McDermott. My name is Megan Atkinson, and I am the agency's Chief Financial Officer. So I think I'm going to kick us off a little bit and then pass the baton over to Tanya to take us through some of the detail. So you all know, you're very familiar with our annual procurement cycle. And so even though this is the first time that we've come before the board meeting to publicly talk about where we are with calendar year 2024 procurement and rate results, as you all have been having your meetings through the spring, Tanya and her team have been working with support from our contracted actuaries in both UMP rate development, as well as negotiations with Kaiser Permanente, our fully insured carrier, to secure what we're now at, I believe, a 4th round of rates. And so we will walk you through sort of a refresher on the timeline and the process, and then get into showing you where we are with final rates. As Dave mentioned earlier, these rates have now been shared publicly. And of course, we have the historical board resolution about once we've shared the rates publicly, that the carriers cannot, of their own accord, offer new rates. So we believe we are at the final point, but I know that we'll have conversation about that today. And so with that, I think, Tanya, why don't you walk us through the detail, and I'll just interject occasionally.
Interject as you please. All right. First up is just the timeline. Beth just walked through this timeline, but from a financial perspective, I'll just reiterate, we did start drafting those RFRs really early in the year with the financial terms to be incorporated within the RFRs. We did get our first round of rates back in May, and here we are today in July, presenting the final draft rates for your action next week. First up, we're going to talk through employee premiums. So on the next slide is just a refresher of how we calculate the employer medical contribution, as known as the EMC. The EMC, the employer medical contribution, is benchmarked off of the UMP Classic bid rate. It's benchmarked at 85% of the total bid rate for UMP Classic. So as an example here, if you take the $800 bid rate in that top blue box, multiply it by 85%, you get an employer medical contribution of $680. We then subtract that from the $800 bid rate, meaning the employee premium is $120. On the next slide, you can see that we apply that same employer medical contribution of $680 to all plans in the portfolio. So across the top here, you'll see three illustrative examples of bid rates. We have a Plan A that's $700, Plan B $725, and Plan C $800. They all subtract the same $680 employer medical contribution to leave the remaining portion the employee premium. Plan A is $20 for the single subscriber, Plan B is $45, and Plan C is $120. That's just a refresher as we get into the next slide, which will show the actual employer medical contribution for the proposed plan year 2024 employee premiums. So to orient you to this slide, across the left you will see each of the plans sorted by carrier, starting with Kaiser Northwest, followed by Kaiser Washington, and then the Uniform Medical Plan. That first column is the proposed 2024 single subscriber employee premium, followed by the middle column being the employer medical contribution of $702, and the proposed bid rate in the far right column, that's the dark blue. I like to think of the math in the opposite way, starting in the right column with this, which is the total bid rate, subtracting the $702, and the remaining portion is the employee premium. As a reference point, for 2023, the employer's contribution was $665, and it's increased to $702 for plan year 2024. Let's go to the next slide. I think this is where we'd like to spend some of our time today. I'll start again by orienting you to this slide, and then Megan, I think, would like to spend a few minutes also on this slide. Again, we're sorted on the left by carriers, starting with Kaiser Northwest, then Kaiser Washington, and then the Uniform Medical Plan. Those first two columns are the single subscriber premiums for both plan year 2023 and the proposed 2024 rates. The light blue is the 2023 and the dark blue is the proposed 24 rates. The following two columns are the percentage and dollar change year over year. So comparing plan year 2023 to plan year 2024. And the far two right columns are enrollment, just so you can see which percentage of our active enrollment. Active is the term for our employees. This does not include our early retirees or those non-Medicare retirees. You can see how our enrollment lays out here. So I know there's a lot going on this slide, and just to, really orient your eyes to the right column, let's just take that first row as an example here, and we'll walk through what this means. So you'll see that in 2023, the Kaiser Northwest Classic rate was $172. The proposed 2024 rate is $347. Those next two columns show that the premium increase for a single subscriber is increasing slightly over 100%, and it's having an incremental increase of $175. So the difference between the $347 and the $172 for 2023 is an additional $175. I know that these are some large increases for Kaiser, and we'll address some of that here in just a second. But there is one other piece I want to just point out really quickly. So as you run down this list, your eyes might go right to that red negative $11 here. And we'll just do that same example. So the UMP Classic 2023 rate is going from $135 to $124. That is a decrease in employee premium and a decrease as far as percentage and dollars of $11. Now, this is because there was a change in the collective bargaining agreement for the employer medical contribution. So the bid rate for UMP Classic did increase, but it increased at a rate lesser than the increase to the employer's contribution, and that is a direct change of the employer medical contribution methodology. So you'll see that the enrollment in this plan is slightly over 50%, so 50% of our members will be experiencing a decrease in their employee premiums. Megan, do you want to
I think
add
there's a couple
few
things we
things?
want to clarify. So Tanya, the numbers in front of them, they include or don't include the benefit changes Beth was describing?
They include all of the benefit design changes that Beth just walked through. Thanks for that reminder.
So we've got that all rolled up now that you can see. So then what you're looking at here is where we are in the final round of rates that we've received from the carrier. And I just want to do a call out to our partnership with Kaiser Permanente because we were working with them through the weekend. Many phone calls Saturday, Sunday, We got the most recent round of rates from them, I believe, Monday afternoon. So I want to extend my my appreciation to them for continuing to work through with us. We've had many very difficult but yet candid and I think very collegial conversations with them to better understand their financial positioning, talk through the financial model and the structure of our quality model, our risk adjustment methodology, and also the calculations around the employer and employee split and the implications with the collective bargaining. So I think this year, you know, we always do multiple rounds of rate development and negotiations. I think this year we the conversations have gotten to a deeper level, and I just really appreciate, you know, both the support from the board and HCA leadership and the partnership with Kaiser, because it has been a different level this year. So I think what we want to talk through is really sort of, you know, considerations. And I think you guys had a little bit of this a moment ago with the Medicare resolutions, right? And sort of the responsibility and the expectation on you all as board members next week on approving, accepting, authorizing rates. You know, where we are in terms of our rate development and hitting the budget targets we have been provided by the authorizing environment is we are right there. We're right on the budget target that we were provided by the authorizing environment. So we feel good about that. We have been able to bring in the change in the employer and employee methodology, and we have had many conversations, again, really to make sure we understand and that we're able to communicate and share about our financial model, our structure, and what we value. So I think I'll pause and see if there's questions about the numbers here.
It's not about the numbers, but it goes back to kind of Dave, the question that I asked earlier of, we heard a lot of feedback about the First Fill program about people who were notified, but they didn't really get the notification because we're just bombarded with all this information. So this is not going to be a number, even though it's small, it's not going to be a number of people that you could directly provide outreach to in the change. Like, if we move forward with these premiums, like these are astronomical for some of our employees. Like, how are we going to make sure that they don't get stuck in just continuing, like not knowing that the rates are going to change and then realize in that following year, like, oh crap, I now have a premium I can't afford.
Yep, Michaela, at next week's board meeting, we plan to have a presentation by the communications team and our and Alyssa over our customer service wing of the division talk about the transition to open enrollment and some of our strategies. And I can say that we're definitely increasing our communication strategies. One of the things I'll just preview is my expectation is that we're going to have something arriving in everyone's mailbox every week for 4 or 5. Possibly even 6 weeks in a row, a postcard, something that you don't have to take out of an envelope, things that are printed on envelopes, both the front page and the back page of the newsletter. We're going to really need, I want it to be the people who are like, oh, I got another thing from HCA, hopefully by the end of it, by the time we're through open enrollment. So unfortunately, one of the challenges that we have is that we have to rely, the agency's main way to communicate with people directly is through the U.S. Postal Service, through mail. We do package and create messages that are usable to send on by employers in state agencies and higher education institutions, and many of them do that, and we will heavily encourage them to do that. We can't require them to send our messaging on in that electronic format. We also don't have, we don't have a text-based phone messaging relay system to, which some people might appreciate that, other people won't. But we don't have something like that. We do have e-subscription services, but it's voluntary opt-in, and so we have something like 20 to 25% of members who have signed up for that. We'll leverage that the best that we can too. But you're right. Like we're talking about ramping up, increasing our staffing levels at benefits fairs, knowing that there might be more people who are active and coming to those. But we'll talk more about the communication strategy. But you're right. We're not going to have staff members calls. A couple 100,000 people. That one's going to be a little bit rougher. But they were definitely not just using our same communication strategies and planning that we always have, knowing that this does represent, in the PEB program, we haven't had an active open enrollment that requires you to engage in many years. I think when Scott Palafox, if you remember him, my former deputy, he said he didn't remember the last time he had to do an enrollment in his career after he first became a state employee, and he just retired. So it's been a very long time since an active open enrollment, and so it's going to be really important to say, if you haven't engaged in a long time, this is the year to engage, just to check in and make sure, because there are benefit changes that are happening, there are premiums that are changing, and that's for both the Medicare portfolio, the PEB non-Medicare portfolio, and it's also the SEB program tomorrow. So it's kind of a full court press on all three of the parts of our population. Okay, well, John and then Monica.
Quick question, these rates are going to be the exact same for SEB?
No.
No.
When did you?
The SEB rates are completely separate from the PEB rates. They're in two separate risk pools. We rate the population separately. The SEB portfolio also has different plans. So we do a complete different rate development for the SEB program.
But we see the same magnitude of
Yes.
increase, right? So the issue of Kaiser's rate increases compared to UMP's, that is the same dynamic. On the SEB side, the SEB program has always had the EMC methodology, so that's not a change for them. They have always had that.
Okay, but the percentages are pretty similar, particularly with
Yeah, I think the ending point here in the dynamic is the same, yeah.
Thomas had his light on for a bit.
Well, I think John actually just addressed kind of what I was going to ask. So I am currently, let's play pretend, I'm currently UMP Classic active employee, and I'm going to look at what I'm paying monthly this year, $135, and I'm going to see a decrease to $124. Or I'm a Kaiser Classic enrollee, I'm going to see my 167 increase to 226. And I guess what just more curiosity than anything. So the SEB plans are pretty much identical to these plans for active employees, or different?
There are some similarities and some differences. So for example, there's only one high deductible health plan that qualifies with an HSA in the SEB portfolio, and it's a UMP plan. So there is no comparable Kaiser Northwest CDHP or Kaiser Washington CDHP in the SEB portfolio. There is Sound Choice is the most similar, but even today, if you just looked at 2023 benefits, there are certain benefit coverages that are different in the SEB program than the PEB program that are actually being proposed with the rates for 2024 to align more with the PEB program. So there are a couple of features today that SEB members experience on a few of the Kaiser Washington plans that are richer than the rest of the commercial market, or much of the rest of the commercial market, as well as PEB, but that alignment is being proposed right now. So there are a lot of differences, but there are similar level deductible plans and out-of-pocket maximums. Those macro aspects of benefit design are fairly similar across the two portfolios. There's also actually in the SEB portfolio, there are plan designs that have a $1,250 deductible, and that doesn't exist in the PEB program. So yes and no, Tom.
Okay, and then the other piece of that is, so the non-Medicare retirees that are non-Medicare that have been in SEB, are they going to have to transition to the PEB, and then their choices will slightly alter as well because the plans aren't quite in alignment?
That is what happens today, and that is what will continue to happen in 2024. All individuals who retire, their eligibility shifts to the PEB program, whether that's non-Medicare for this risk pool or Medicare, the risk pool we talked about with the board this morning.
Okay. All right, thank you. Elliot?
Yes, my concern is that.
You actually turned off.
My concern is also I'm not mechanically adept. A lot of the retirees, or not retirees, active employees want and respond to electronic communication. I can tell you that relying on the HR within the agencies it's not very reliable, okay? That's all I'm gonna say. Is there any way to reach the electronic generation without relying on HR, who really basically is serving management?
There are a couple of ideas that we can possibly work through, but one of the challenges we have is right now it's an opt-in process. But there are, maybe Lou, you might be able to speak to a little bit. So we have quite a coordinated deputy level meetings of cabinet agencies that sometimes when there are important issues like this, it helps elevate on senior leadership's eyes in agencies, and that's a mechanism we've thought about.
When Dave was talking about getting the agencies to send stuff out to their staff, that's going to be a point of focus this year. I will bring it up at deputies. I know Sue's going to bring it up at cabinet. Yep, we got state HR here, so we're going to talk to them about it because it is kind of an extraordinary event and we want to make sure people are aware. So we're going to hit it full blast.
We'll definitely appreciate coordinating with state HR, Michaela.
Yeah, state HR happened to be sitting right over there.
And
Well,
Monica.
this is Monica. I'm just going to jump in because I've had my hand up for a little bit. What my idea is to actually have people take over the HCA social media accounts, and I'm going to actively volunteer to go ahead and do that. I really want to talk about, and I'm going to speak as an individual first, and then ask my question as a board member. So, as an individual, I just want to put out there, I am an employee, and I have been a Kaiser Permanente member for 30 years. Right, 28 in California, 2 here in Washington State. And so I want to just sort of name that as a disclosure. My question is not one that can be answered, but I want to say it on the record so that we can be thinking about this. And I asked this question both as a nurse, but also as a professor at the University of Washington. And that question is, have we had careful enough consideration for the trend and the precedence that this sets in terms of being able to move forward these costs at such a high incremental bar in a year's period of time? And it's a rhetorical question. I'm not looking for an answer, but I am very concerned about the not just rate increase, but also the precedent that it sets. And so I want to set the tone of, as we're waiting and preparing to hear comments from other individuals that needs to be said. And so I'm saying it.
I appreciate that. Michaela?
Yeah, I appreciate, just amplify what Monica said too. And I guess the question is, and maybe this is for the next meeting, if we opted not to vote the rates in for Kaiser because of the increase that it was, what would happen?
No, that doesn't have to wait for next week. It's actually kind of I'll pick up the breadcrumb I dropped this morning after the Medicare vote, where I talked about how, as it stands today, there are no plans for employees and non-Medicare employees for 2024 because each year there needs to be an affirmative approval of the benefit design, and we wrap that up as a vote on the premiums. And so if a resolution is not passed or a plan is not authorized, that plan closes on December 31st of 2023. And so then as part of open enrollment, we would be communicating a closure of a plan or a carrier's plan for 2024. So an affirmative vote is needed in order for the plan to be authorized and premiums to be set. Otherwise, the plan does not exist.
So could they, I guess this follow-up would just be, does that mean we would be forced to move forward with just a single option, or could we open up to for an RFP for a secondary option?
Okay, I appreciate. Thanks for clarifying, Michaela. The high water mark for plan offerings is what is on the page today. There would not be the ability to do a procurement, add a carrier to the portfolio, do rate development, bring it to the board, and have open enrollment by 2024. So the high water mark for the plan offerings is what's on the page today. There could certainly be conversation and analysis about doing a procurement for future plans. That's also one of the reasons that we've had, last meeting we had John Parton go through the various cycles, and Sean is going to go through the procurement cycle next. We're trying to highlight for people what those timelines look like. There wouldn't be the opportunity for 2024. That's more of a 2025, 2026 question.
So currently, to kind of follow that. So currently, as of right now, for 2024, the only thing we have are Medicare plans. So right now, if we don't do anything else, that's all we would be covering are people who are Medicare eligible.
That is correct, Tom. And when we woke up this morning, no plans existed for 2024. As of about 9:30 this morning, we have Medicare plans to offer for 2024, but neither the SEB, there are no plans in either SEB or the PEB non-Medicare risk pool as it exists today at 10:35 on July 12th.
Kurt, and then John.
Thanks. So I would share Monica's concern, just for the record. But also I have a question and a request. My question is, I very much appreciate these graphs that you put together. They're very helpful. But for the percentage increases, it only lists the subscriber tier, and I was curious, and this is the question. For UMP Classic, we have a reduction. Does that carry through the remaining tiers as a
It does.
reduction?
It does, Kurt.
Mm-hmm. It does, okay.
Yes.
And then I guess the request would be in the future, is it possible to get that kind of information on all the tiers? Because obviously many state employees have a spouse and or children. And so it would be helpful for me to see all of those if possible.
Yeah, definitely, Kurt. We can work on that. On the next slide, we do have the total premiums by tier, but not the percentage increase. Or decrease by tier. We do have the non-Medicare retiree rates coming up in a couple slides that you can see are pretty close. And it's a little confusing, but I can talk you through that on how to get there. But I definitely think we could put something together for the increase and decrease by tier.
Thank you.
Yes.
If the board were to reject, as Mikhail had suggested as a possibility, the employee and non-Medicare retiree rates today, would KP still be obligated to meet the Medicare rates? Would they drop? Do you think they would drop the Medicare program?
They are independent questions, and so the board has already authorized, and there would be the obligation for the Medicare portfolio. So I just want to make sure that I understood
Could the KP pull out of the Medicare? Could they pull back their Medicare proposal if their rates for this plan were rejected?
Not for 2024, whether they,
So they're obligated for 2024 on Medicare?
Correct.
Thank you.
I do also want to clarify, I think it came up, I kind of heard it in a couple of different questions. I'll save that whenever we get further in the presentation.
I think that Chair McDermott, if I might, I'd like to respond to Monica's rhetorical question. And Monica, you mentioned that it was a rhetorical question about sort of what these increases are doing in terms of setting the bar for acceptable future rate increases. And, all of us wear multiple hats when we come and conduct the board meetings and conduct this business. And, the agency also administers or supports the Healthcare Cost Transparency Board, where Sue, I believe, is the director. And my staff participate in data and collections for that effort. And so we have actually discussed internally, as well as with KP, the implications of a large increase this year, what that means in the market, how it either aligns with or seems as an outlier of the current health insurance market. We also are looking and to see how other large employer groups and how their procurements are coming in. We have talked extensively with OIC also to understand the Kaiser Permanente financials, and we are watching to see what the CalPERS board, I believe they're due to take action next week, and they have obviously significant KP offerings in their portfolio as well.
Thank you, Megan.
Thank you for that. I appreciate that response.
Other questions or comments from the board? Tanya, back to you.
All right. On the next slide, Kurt, this shows a little bit of what you're asking, but I don't think the direct question. This is the total employee premiums by tier. It doesn't show the percentage increase or decrease or the dollar, that incremental increase or decrease, but it shows the total premium. So it shows the subscriber rate and then the subscriber and spouse or state registered domestic partners, which is a multiplier of, it's a 2.0 tier. So you take the first rate and it's a times 2. The next tier is subscriber and child or children, regardless of how many children you have enrolled on your account. And that is a 1.75 of the single subscriber tier. And then finally, on the last column is the subscriber and spouse or state registered domestic partner and child or children, again, regardless of how many children you enroll. And this is times a 2.75. So if you wanted to take the dollars from the previous slide, you could do that math and multiply it times those tier ratios.
So Tanya, just for the simple math one, on the prior slide, we saw a negative $11 for the single subscriber rate.
Times it by 2.
Times it by 2, that means that the second column on slide 8, subscriber and spouse registered domestic partner, that represents a $22
Correct.
decrease.
Correct. Okay. This was the last slide on the employees. So before we move on to the non-Medicare retirees, are there any further questions about employees? So moving on, next slide, please. This is the non-Medicare retirees, which Dave clarified earlier. These are those retirees from either the PEB or PEB programs who retire but are not yet Medicare eligible. They can choose from any of the plan offerings listed on the left, and they pay the full bid rate plus a small administrative fee. So as you walk through this, those same tier ratios apply, like I mentioned, for the employees. So you can see the 2023 rate compared to the proposed 2024 rates for each of the 4 tiers. And on the far right, you'll see the 2023 versus the 2024 change in the single subscriber rate in terms of percentage and dollar. Now, this is the total bid rate that the non-Medicare retirees pay plus that administrative fee. So there's no employer medical contributions subtracted from these amounts.
Before we leave this slide, I think it's a really good illustration. I've already been asked this twice in the last 24 hours. It's that relationship of everyone hones in on the prior slide of negative $11, or on the prior set of slides, the negative $11, and that is atypical in what everyone is experiencing in the market. So I've already had the question of like, how did UMP do that? I think it's important to highlight right here on this slide under the subscriber column, you see UMP Classic 2023's bid rate of $805,832. UMP was not immune to the pressures that the entire healthcare system and insurance commercial market is experiencing. You can see that evidence right there on those slides. The overall cost did go up. The difference and why there is a decrease is the collective bargaining agreement, the methodology, and the additional investment that was made in that collective bargaining agreement and its implementation this year. That is what drives that red, negative, positive experiencing number for state employees. Over 50% of them who are in UMP Classic, that's what explains that outlier from a insurance market perspective. So just wanted to put a bow on that one.
That is correct, Dave. So the UMP Classic bid rate increased 3.3%, while the state's contribution increased 6%. So a larger percentage increase on the state's contribution for employees. Okay. Any further questions on medical before we move into the other benefits? Okay. So moving on to the employer benefits, similar to medical, these include any design changes that Beth would have walked through. For dental, there are none, but I will just walk through these dental premiums. For employees, I want to remind the board that these are 100% employer paid, and for retirees, these premiums are paid directly by the retiree. When we look at these 3 dental plans, we can compare the 23 to the 24 premium, and again, the single subscriber premium change in terms of percentages and dollars. On the first line, you see Delta Care with no increase. And that is because we are in a rate guarantee on this plan from 23 to 25, so there'll be no change next year also. And then when we get to the second line, the uniform dental plan, this is our self-insured dental plan and functions similarly to how we do the rate development for our uniform medical plan. We have a third-party administrator for uniform dental plan, and then the rest of the rate is developed based on actual claims experience. So that third-party administrator portion of the fee is in a rate guarantee through 2025. So that remaining 36-cent increase is based on claims experience. And then the last one is the Willamette Dental Group. And while there is a rate increase for this plan, there has not been a rate increase since 2019, and this will be in a rate guarantee from 24 to 25. Next up is our life and AD&D and long-term disability premiums. So as a reminder, basic life and AD&D and employer-paid LTD are employer-funded, and there's no rate changes for 2024. And then we have our supplemental life, AD&D, and employee-paid LTD. Again, these are employee-funded with no rate changes for 2024. And just a quick reminder that our retirees at the time of retirement can enroll in retiree term life insurance, but there is no LTD offering for our retirees. And then next up are the proposed resolutions. I think we've had a decent conversation already about the resolutions, but how these are structured is they're currently teed up as one resolution per carrier. So to orient you to this first one, I will not read all of them to you, is the proposed resolution PEB 2023-12, which is the Kaiser Foundation Health Plan of the Northwest, KPNW. These are the non-Medicare 2024 premiums. So these are the employee premiums as well as the non-Medicare retirees. And it reads that the PEB board endorses the Kaiser Foundation Health Plan of the Northwest employee and non-Medicare retiree premiums. And as written, by the board adopting these resolutions would be adopting all of the plans offered by Kaiser Northwest as well as the benefit design changes that Beth spoke to earlier. So we have one of these resolutions proposed for each of the carriers, so followed by Kaiser Washington and then the uniform medical plan. And they read similarly, but changing out the carrier names. So next steps, we will be here next week to ask the board to take action. I will do a quick refresher of the rates. We will include details in the appendix. We'll include, I'm guessing we'll include that additional slide from Beth as well in my presentation. And yeah, so that is it for today. I'm happy to take any questions.
Any questions or comments for Tanya? Harry?
This is semantics, but I've already heard about the angst with these increases, and I guess I'm just a little trouble with the resolution as written. I don't like the word endorses. It, in my mind, it suggests something else. So I would ask if we could consider looking for a different word. It's not going to change anything. I understand that. But personally, looking down the road at next week, I don't know how we can. Well, I don't know where we're going to end up, but I'm not comfortable endorsing something that I don't really like. So if there's another way to say that, I'd appreciate at least giving it some consideration. Thank you.
Other board members feel similar?
Could we use the word accepts?
We'll definitely take this feedback. We'll break out our thesauruses, as well as look at the statute, and maybe there is a word that might more align there. But we'll take that under advisement, Elliot. But I just want to say I saw every board member in the room head nod. I just want to check in with Kurt and Monica.
Yes, I agree with what was just said.
Totally agree. I think we can adopt the premiums, but I won't feel comfortable endorsing them.
How about the PEB board adopts?
I don't want to respond we'll definitely come back with a different word. I hear nominated adopts. I
like authorize.
I hear authorize. I hear accepts. All of these words begin with the letter A. We'll see if there's other opportunities for the rest of the alphabet. But I do hear the concern about, and I'll just say, as I think about, this is just the words we've always used, and we haven't really been in a scenario that nuance has come up, and language does matter, and it does send important messages. So I definitely hear what the board's saying, and this is exactly the opportunity. When we ask for feedback on the resolutions, this is the exact thing. So we can look at it, and we'll definitely bring something back that uses alternative words. For this, I would appreciate understanding from the board if you want that as a universal change in the resolutions, or if you're, if you want that as a universal change in the resolutions.
I would say yes.
I heard one of each.
Yes,
For all the plans?
I think so. Well, I think so, myself, because when we say we endorse something, it sort of suggests something beyond authorizing or approving or accepting or one of those other A words. That's just my thought.
I wish we could go back to the one for UMP with the retirees and use the language that was proposed, but
So I hear you saying, Elliot, that that's a more universal change that you're interested in. And Michaela, you started to say distinguish.
I mean, I agree with Elliot as well, and I like the idea of having two options so that you could distinguish between the two.
Gotcha.
So not saying for this one, I would say I would agree with Harry's request, but that in the future, not necessarily limiting to one or the other, but I think there may be times where we do want to endorse.
Yeah.
Okay.
And that was the point, this is Monica, that was the point I was gonna make. I would like a case by case basis because I think it matters that we not use the term endorse when we don't mean it.
Okay.
John?
Yeah, I just want to weigh in a little bit on the issue of those who are participating in the KP plans. They may very well be in the middle of treatments with physicians or physician groups. And 5.5 months just isn't enough time to let them wind down. I do think hopefully the market will adjust to this in the future years if these rates stay where they are currently. I know it's a terrible price to pay for those folks who are sort of wedded to KP for 2024. But I don't see an alternative because I think you have to give them the option to have that ability to keep with their current providers, especially if they're undergoing treatment. And my guess is that a lot of these folks are older, who have been with group health for a long time, and they don't want to give up their providers. So that's my thought.
Michaela?
Yeah, and this, I don't know if this question is appropriate for you. I think it's more appropriate for the next tab, but I want to pose it now just in case anyone here, and looking at you, Dave, especially if want to respond. And just for context, like being in state HR, we have that kind of centralized employee data, and we're looking at just turnover and employee engagement trends continuing to go down. And part of our idea of like trying to keep a healthy and engaged workforce, employer benefits and like the affordability of the benefits is one of the biggest attractors we have as a state employer. And especially with our kind of low income employees, Kaiser has always been the option that allows them to say, because people don't come to state government to make a fortune. They come here because we're public servants and we care about the people that we serve. And so I appreciate them. I know that you all, like you had said, Megan, that you've worked through the weekend to try and get these rates that there are, but is there any option to relook at the rates? Because it just, I struggle with how much of an impact this is going to be. And like you were saying, that there are people who are in the middle of treatment, or there are people who, no matter how good of a communication plan we have, that are going to miss this. Again, I go back to people with limited English proficiency or other types of barriers to how we receive communication. Many of our employees who are low income don't have daily access to a computer.
and may have unstable housing, and those are the people that are being impacted the most. And I can't see how this change can not come at just such an impactful cost to those employees.
What I can say, Mikhail, is, and I get, it's a great opportunity to highlight, we didn't publish the rates until yesterday morning because we were working on them through Monday afternoon. And normally we publish them. And so some members of the public who are very attuned to, we publish things on Monday afternoon, we're like, what's going on? And that was the rates that we would have published on Monday would have been different than what were published on Tuesday. And they were better on Tuesday than they were on Monday. And so that I wanted to put that in the record, especially for members of the public who are very engaged in the activities and wondering, oh, what was the delay? Well, the numbers were different on Tuesday than they were on Monday because of work that was happening. So for future, the timeline, we are currently set to bring these back to the board, these resolutions for action next week. If you look closely at your board calendars, there is an extra set of meetings that are scheduled that we were anticipating canceling them, but that does give a week buffer for additional conversation. I think it would be great. You said, you kind of prefaced, you're like, this question might be for the next tab, it might be for now. So we have the space for an additional week of engagement if there is engagement to be had. So it sounds like you're going to ask that question when our Kaiser colleagues are up here. And if there is additional conversation for Kaiser, then we will all be working as diligently as we can, because we're all state employees too, all of our friends and families, and have, roughly 1/3 of our neighbors. And we want to bring the best rates for everyone. So we have that space if there is reason for it. It is important to know that because of the resolution, Kaiser can't pro-offer those rates. So we have to ask them for that, and we would be doing that with the board's action. So I guess I'd say, let's see what happens in our next presentation.
Other comments or questions from the board? Tanya, thank you so much. Appreciate it.
Thank you.
Next up, we have Kelly Meehan Cook, Director of Strategic Account Management from Kaiser Foundation Health Plan of Washington, and Jennifer Stacy, Interim Vice President of Marketing, Sales, and Business Development from Kaiser Foundation Health Plan of Northwest. They're going to be joining us today to provide some insights and answer any board questions related to the 2024 plan offerings. Kelly and Jennifer's materials are behind tab number 8. Welcome.
Thank you, Chair. Liv McDermott and the board, we really do appreciate the opportunity to be here today and talk with you. For the record, my name is Kelly Meehan Cook, and I'm the Director of Account Management at Kaiser Permanente, Washington. And with me here today is Jennifer Stacy. Jennifer is the Interim Vice President of Sales, Marketing, and Business Development at Kaiser Permanente Northwest. In addition to us here, we also have 2 of our directors on our underwriting department, and they're in the audience here as well. David Holt from Washington and Chris Mazurowski from the Northwest region. So thank you. I'm going to turn it over to Jennifer, and Jennifer's going to walk us through the first slide. We do have just a couple of slides that we'd like to share with you today, and then we're just going to open it up for questions.
Yeah, thank you for having us. I'd just like to acknowledge, we understand that this is a very difficult time, and these are very difficult messages and rates, and we have been partners with our state employees and served the members of the state, and as we talk tomorrow, the school districts for many, many decades, and don't take lightly the impact that these have on our members, on your employees, and what that looks like. So wanted to just set a little bit of context around what is driving this in general, and then we can also talk about some of the specific factors in the state accounts, because it's really multifactorial here. But in general, as we talk about just healthcare, and it's been referenced earlier today, inflation, Kaiser Permanente, just like you, just like your members, is not immune to the inflationary pressures that we've experienced in general across our economy. They are accelerated, I would say, in the healthcare space with the labor shortages that have occurred. You know, we knew going for years that there are shortages in RNs, in MDs. We've been working to try to fill that gap and to solve that for many years. The pandemic absolutely accelerated that issue. So we're seeing just healthcare shortages in general. So to give you a perspective, and I'll speak with specifics to the Northwest, but this is broader. You know, vacancy and turnover rates historically for RNs, registered nurses, have been about 5 to 7%. In the US in 2022, we saw 27% vacancy rates in RN ranks. At Kaiser Permanente Northwest, it was lower, but it was about 18. So what that has translated to is significant increases in overtime for our staff, as well as significant increases in agency use to fill that gap in staffing so that we could continue to serve our members. Agency use in the Northwest increased about 5 times from pre-pandemic, and overall the cost for that just skyrocketed. I'll talk a little bit, because it's one thing to say what's wrong, and then I'll talk a little bit about what we're doing about it, because I know that's the most important thing. We'll talk a little bit about the demand in care as well. So as you know, during the pandemic, we experienced this fundamental shift in how people received care, when they received care. There's been a good bit of deferred care that we're working through at this point. To give you an example, in our EDs, or emergency rooms, while the visits are up 5%, what we're seeing is the acuity of those cases, so that how sick people are coming into the ED increased about 47% in 2022. So we're serving more members that are sicker right now than we have been, and getting through the preventive care as well that was delayed to stop that trend has been pretty significant. So let's talk a little bit about what we're doing, because I know that's the real important piece. So huge focus on trying to fill all of the core positions that we have. We're making good progress on that. I think many of you know that Kaiser Permanente is a largely labor-supported environment. So because of the wages, the benefits, the treatment of our staff, we have experienced less turnover. But we do need to pay them what they're worth, right? And you've seen, I think, throughout the state. What we're also doing is working through our contractual relationships. So one thing
Can I ask
that
one quick question?
Oh, yeah.
I just want to make sure, you know, because before you were talking about the upward pressure, now you're talking about the downward pressure.
Mhm.
And I'm wondering, how does filling all these vacancies, because I'm thinking of our own budget and how we do state budgeting.
Yeah.
How does filling all these holes put downward pressure on cost?
That's a great question. Thank you for the clarification. So because agency staff is so expensive, so oftentimes if you're bringing in a traveling nurse, they're making multiple times what a permanent nurse would make. And it decreases efficiency, frankly, right? When you have permanent staff that work with their, we call them dyads or triads, so they're familiar with where they're located, who they're working with, what the procedures are, things like that. It's not only a cost-effective or more cost-effective wage, it's also a more efficient way to drive care. So thank you for that. So the staffing piece is huge. I'm sorry.
Michaela?
Sorry, first of all, I just want to say thank you for coming too, because I know this is not an easy conversation to have. Kind of similar to Lou's question, I think, or I guess just seeing how this has impacted you, and really appreciate that understanding. Do you have any kind of understanding of why Kaiser seems to be impacted so much more than other healthcare providers?
Yes, and what we believe to be true is that we're impacted earlier than others, rather than completely differently. And for instance, in the Northwest, we're a hospital region, right? So most of our care is provided at our own hospitals. We do have contracts with other hospitals, but we're both the provider and the health plan. And I think if you look across both Oregon and Washington, what we're seeing is significant issues, actually across the United States, with hospital systems going out of business, losing money. So our hospital systems in general have come out of the pandemic in serious financial distress. Most organizations that are claim payers, right? So they're moving from premium to pay claims and provide that coverage, have multi-year contracts with the organizations, right? So we are seeing, I'll say in the Northwest, one of our largest partners broke their contracts and we're moving, we're saying we can't even hold 2 to 3 years now. We're going to need to, have a substantial increase, but others will negotiate cost increase as they flow through the system and their contracts come up. So in our work with, other providers with consultants that we work with and other large groups, the expectation is that there will be we'll see medical inflation over the course of the next few years. What we have to do, we are increasing our rates. So in PEB, Kaiser Permanente Northwest, we've averaged about 4.1%. This year we're at 25%. And that is unheard of for us, absolutely unheard of. Part of it is driven by PEB. Their utilization increased 18%, so claims went up for the population that we are covering. But part of it is that trend that we expect. We're at a new high water mark, and now we need to work our way down. And just like KP was hit earlier, we also need to recover earlier, right? Because we've hit this high water mark, and all these things we're doing to decrease costs need to go into effect because this isn't a sustainable situation. So we've talked a little bit about staffing. There's many, many different ways. I'm sorry, John.
Yeah, I'd like to ask a policy question, which is probably 30,000 feet. I have a background with Kaiser with group health. I was on their advisory board over 20 years ago, and I was their lender about 40 years ago. And we used to talk about how it was a real advantage to have the payer and the provider on the same organization. But now we're seeing more and more acquisitions of providers by payers. It's a trend throughout the country, not just here in the Northwest. Do you think that is helpful or harmful to the overall healthcare system, and for our purposes, to how rates will be affected in the future?
So I'll speak for Kaiser Permanente. We have traditionally delivered lower than market average rates, and we've done that for years. And we do that by an extreme focus on prevention. We do it by quality. We talk a little bit in the next slide about where the quality metrics land for KP. And we know that in the long term, people are better if they're healthier, right? You're better in your workplace, you're better in your life, tend to be longer lived. So we absolutely believe that an integrated system in which we can deliver the right care in the right place at the right time is where healthcare needs to be. We have a real focus on equity, diversity, inclusion. We have a real focus on helping address social determinants of health, which many of our communities are struggling with. But that's kind of grande, right? And we're talking about, unfortunately, a moment in time in which, as I kind of mentioned, we're experiencing a fundamental shift in healthcare and the way it's delivered. and we're a little bit on the tip of the spear, and I can tell you nobody wants to be there, right? I don't want to be there for your employees. Don't want to be there, you know, for myself. But I don't think that the fundamentals in which we're operating, that hasn't changed. And I also believe that because we have greater control over the, over the full spectrum of care, we will be able to bend the trend and keep the quality. So just kind of for instance, in the Northwest, of some of the work we've done. As I mentioned, emergency rooms have been quite full. We've had issues being able to step down out of hospitals, right? Because our skilled nursing facilities, all rehab facilities were impacted by the pandemic as well. So we're seeing longer stays of care. We're seeing more people get that urgent care. So one of the things that we've been doing to address the fact that care needs are rising while staff is lower is to do heat mapping, right? We can tell when people are coming in, when they have the highest need, and when they are, what care they're going to need. So we've adjusted in the Northwest our urgent care hours to put staffing when people are there more, and are incrementally cutting out, 10 minutes here, 12 minutes here. It doesn't sound like much, but what it does is add a significant number of appointments and allow us to care for people faster without increasing staff. So we're looking at every day in every way, how do we get more out of what we've got, more waste out of the system. And I do believe that this system will bend that trend back. We've bent it further than typical, and we'll get back there. But this is just a really tough year in which we need to adjust to current market so that we can continue to deliver the care to our members.
And Jennifer, I know Monica has her hand up. It's harder to see, so I want to,
Yeah,
Monica,
thank
if you can jump in.
Yeah, I mean, I really appreciate that last statement, and I am hoping that, it's not, like, I can appreciate the fact that rates need to increase. For me, it's the magnitude and the timing that I think is really problematic. I also want to put into the room another point that I think is really important to the policy question. And that is in Washington State, and people who know me know I work in reproductive health rights and justice. In Washington State, 1 out of 4 of our hospital beds are religiously affiliated. And so as we continue to have this discussion and this dialogue, I think that there are still pieces of this, like I understand the financial challenges, but there's also this whole other notion that religiously affiliated healthcare is going to become the dominant, option for individuals. And I find it really, really hard to talk about, equity, diversity, inclusion, justice, all of these different things without sort of really naming that piece of we need to have options for individuals who are not religiously affiliated. And I can't stress this enough in the current moment that we find ourselves in. I appreciate the fact that we need rate increases. For me, it's a question of the magnitude and the broader ripple effects that I don't necessarily think are being considered in this context.
Yeah, thank you, Monica. And I agree, a 25% rate increase, it's unheard of for Kaiser Permanente. It is where Kaiser Permanente Northwest, because we are the highest one, so I'll just address that straight on. It is where we ended up. We've had previous conversations around the mechanics of the situation, the way that, we talked about the EMC earlier, the employer medical contribution. We talked about the risk adjustment earlier, and we won't go into that this time. But it does translate from, a 25% increase, which still puts the Kaiser Permanente Northwest Classic premium that we receive the lowest. We receive less money for that plan than any other plan, but it does not stop the fact that our members are going to experience a considerable increase in their employee contribution. So I don't want to discount that fact, but I do hope it helps you understand our commitment to continuing to deliver care in an efficient, effective way, because what we receive for that care it does show a level of efficiency to deliver.
Thank you for that response. And I also want to sort of push back on the comment that was made earlier. I'm not necessarily sure who made it, but for, Kaiser enrollees who are not necessarily in treatment, but those of us who have been members for a long time, who are relatively well and healthy and are employees, we will consider that cost piece very significantly as opposed to direct relationship with providers. And that's why I think having a broad communication plan, to Elliot's point, is really going to be crucial, because early career and mid-career folks like me aren't necessarily going to have, I think, the loyalty that's being assumed in the retirees.
Well, so that was going to be my question, and I'll preface it by saying, like, I'm trying to figure out how to word this to where it doesn't sound snarky or like threatening, but just from like a point of curiosity of, I do predict that a lot of people, if we get the information out to them and in an accessible way, will leave Kaiser. And has that, I mean, I was trying to do the math quickly, and it's about 30,000 plus state employees that could leave. Have you factored in how that might impact your ability to bounce back, as you've described, like trying to in future years, if you lose that much of a base of enrollees?
Yes, so I agree with you, right? People, their resources are tight, and healthcare is a choice. And we try to earn the business every year, right? And every time we talk to someone, in every way we serve them. We are facing a reality where we know that some of our members will have to make a different choice if given these premium rates. We hope that people will be able to stay with us, stay with the doctors they appreciate, ride out this year, but I'm not naive enough to think, right? And it'll be important for people to have the choice. To your point, yes, we've looked at what do those losses look like. We also have had to look at our entire block of business as we serve all of our members, and the losses experienced. We talked a little bit last time about the millions of dollars in losses that were experienced. With these pressures do have to be kind of adjusted. And we talked earlier last time too around the way these calculations are gone. Even if we dropped our rates by 10%, we would be even lower cost coming to KP, but our employee rates would still be higher than our competitors. And so, all of that has kind of gone into that look.
This is Kelly, and I also wanted to point out too that the education piece is extremely important. And we will be there right through all of this, through the open enrollment season, in full support. So with the Washington, we do have some additional plans, a portfolio plan, so we can help educate through that as well to see what the right fit would be. We know that these members have, and your employees have a close relationship with their providers and their healthcare team. It's difficult to make that decision on whether or not they want to, start over with another provider out there. So if we can come up with ways in which to support that through the plan design, we certainly will through open enrollment. So we're here.
Yeah, I have a question. I don't know if you can answer it or if you've thought through or worked through the numbers, but when I look at this, I look at the sound choices, a possibility of a migration into, because while the percentage increase is significant at 50%, the dollar amount is more reasonable at $23, the chart I'm looking at. I don't know how much potential there is if somebody says, I want to stay with KD because I like them. How much potential there, because those counties are limited. how many enrollees might potentially be able to move into it? Is it a significant number that could move, or is it just a plan that's already pretty much maximized for those service areas? Thanks.
You bet. Good question. I don't have the actual numbers on the specific areas in those specific counties, but any of the individuals that are on another plan that are in the core counties where we have our owned and operated facilities, they can certainly move on to that plan. And they would have substantial savings there.
And Kelly and Harry, I thought this question might come up, so I have a little bit more granular numbers to share. So just to highlight, the service area for Sound Choice is King, Kitsap, Pierce, Snohomish, and Thurston counties. Also Spokane, but that's a limited number of providers, so I don't want to oversell the breadth of options in the Spokane area, but it is part of the service area. If you look at the subscribers, so I just did subscribers, I didn't do member lives, because all the numbers we've shared are subscriber based. There's about 24,500 subscribers in classic value and CDHP who live in those areas that could that live in those counties, and about 70% of them, there's about 24,500 subscribers between those three plans, and about 70% of them live in the service area and have the opportunity to consider Sound Choice. The other 30% do not. So it's about 17,500 of the 24,500 subscribers who don't currently enroll in Sound Choice and could.
So this sort of leads me to what's in the back of my mind, which is part of your strategy is to move people into that plan. Am I wrong?
I would say you're wrong. However, we definitely love to have people more into our owned and operated facilities. However, we really want to provide the choice. And that's why we have the other plans, which have been extremely popular over the years.
John? Yeah, I'm interested in your increases in private employer group plans other than ours. Some of the larger ones like Boeing, Amazon, Microsoft, are they seeing the same kind of increases that you're showing us?
And we can probably ask some of our underwriters if we need to here. I can tell you though, we are seeing double-digit increases across large group, individual and family, and small group. So this same dynamic is affecting all over.
Yeah, my concern is that if that does happen, and you see a loss of members, significant loss of members, and also legacy members who are individual members now, will that affect your service that you provide? If it's a significant loss leader for you.
Go ahead.
Yeah, so, to answer your question from the Northwest perspective, our average commercial rate increase is higher than we have experienced in the past. It is in the high single digits. So, but that means some are very high and some are lower. Obviously, the Healthcare Authority, they're at the top of our capped, so we cap our rates. So if you're calculated above 25%, we still stop at 25%. And for the Northwest, both SEB and PEB, we're capped at 25%. We are looking, of course, at the market and trying to determine, okay, what does that mean to overall rate position? Because we are, we're well aware that money is a big deal, right? How much your premiums are and how you relate to other choices that people have to drive behavior, because healthcare is not a small dollar amount for a lot of people. It depends a little bit too on how employee contributions are calculated. So in cases where they are highly leveraged, it is a very different buying pattern than in those where the employer absorbs, more of the cost without the leverage. Overall, though, I do expect that we will see a decline in membership, knowing that we are in front of the market with this. And we look at that when we make our staffing our staffing requirements. You know, as you know, since you have experience with group health, when you're looking at a budget-based system that owns the hospitals and the medical office buildings, it is very important to try to predict what the membership will be so that you can staff accordingly. And that is part of what we're doing when we're looking at staffing overall.
Yeah, I was just concerned that, I know we've been negotiating very hard, very strong, but I'm just concerned that we're getting the best rates. And if you're giving better rates to Amazon, Microsoft, Boeing, then that would concern me.
So groups of this size are experience rated. So as I mentioned before, PEB utilization for KP Northwest went up about 18%. So paid claims went up 18% from prior to current, what we were looking at for the renewal. Not every group experiences that level of utilization increase, but all of our commercial groups have experienced a higher trend expectation, in that we are looking forward to say, what is the cost of care going to be? So that is consistent across the commercial block of business for us. And it's adjusted depending on, is part of that utilization, how much of it is prescription drugs, how much of it is actual medical care. So we use some same trend rates adjusted for specific group scenarios, so that it is fair and equitable.
Shall we move to the next slide? Okay.
You have it? Yeah.
You have a question?
Tom's got a question. So, excuse me if I tend to flip back and forth here a little bit, but when we talked last, I remember I made the comment I'm a bottom line kind of person. And when I look at these proposed rates and look at the fact that you're in competition, and I'll just use the active example here. Uniform has 73,000, almost 74,000. Your two top plans have 21,000. And then I look at the rate increase that you're proposing and the fact that uniform is actually going down a little bit. And I'm concerned about my expenditures for healthcare. I would think that you're really putting yourselves in jeopardy with these rates. And when I asked that question last time, the person who responded said that they anticipated that, but they were thinking that the healthier people would remain with Kaiser and the less healthy would migrate to uniform. But our experience was exactly the opposite. When we raised our Medicare rates significantly, what we lost were people going out of uniform and into the other United Healthcare and yours in particular. So I don't understand how these rates can benefit you in any way.
So I think let's revisit that conversation, because I think it was a little different than that. So and maybe if I say this and then we can discuss. Okay, so as far as when you're looking at the cost to the state, right? So the overall program, the bid rates don't equal the payment rates. So that's part of the discussion I think we were having when we were talking about how let's talk about the payment rate that Kaiser Permanente receives. It's different than this bid rate, which reflects the overall procurement process approved for this program. The risk adjustment piece that we were talking about last time is where that comes into play. So I believe, and I'll explain why I believe this. I believe that the conversation was we actually expect that we would lose the healthier members, just for that reason, because they probably don't have as much of a relationship with their physician. They don't have the as strong of a need as John was talking about to stay with a plan if it's more expensive. it has an impact on the risk adjustment if our overall population shows as unhealthier. And in that conversation where they were talking about what the risk adjustment really quantifies its resource use. And so the impact of having a higher risk score is actually a better alignment between payment and bid rate. Right now, our payment and bid rate are very different because we have lower risk scores. And if our risk score were to increase, then we would expect our payment rate and our bid rate to get closer together. Does that sound familiar?
Well, it wasn't quite answered that way when it was answered to me, but I understand what you're saying.
Yeah.
Other questions or comments from the board? Michaela?
I just like, as you were talking about kind of the risk rate and the fact that, well, you all could potentially lose healthier people going to another one, and just thinking about the fact that really resonated with me about how you all are probably ahead of the curve when it comes to seeing the increases or the cost impact. I go back to Monica's comment earlier around kind of the precedent setting that this is going to have or could have. And so when I think about all the stuff, and I know you're going to get into it and don't want to take away, but all that you're doing to kind of proactively get ahead of this so that you could lower premiums in the future. I just want to put on the record, I don't expect an answer right now, but just for the record, just to put in that request to say if there's anything that you could do to relook at the rates. I know we can't technically relook at them, but I think about the precedent setting and the impact that it could have on everyone else, and that if there's in any way possible to relook at the rates to be able to lower them, just to put that ask out there, because it's right now it's impacting a smaller portion of our state employees, but it could impact in the future everyone, and I worry about that.
And Michaela, a little nuance there. It's like, yes, we have done all our back and forth and we have said no more changes, but if the board were to say, if you want an opportunity to come back one last time, I think the board could instruct the agency to accept that. But yes, we are at the end of negotiation, but the board could ask the agency to do that. And I suppose the question to KP would be, would anything change?
I think if the board instructs us to look at it, we will continue to work with the HCA. I don't know if anything will change. As I mentioned earlier, the way that it's set up, if we cut our rates almost in half, we still wouldn't deliver an employee contribution that is lower than our competition. So we certainly take this very seriously and would go back to our leadership again should the ask occur.
Megan, can you come up? I just want to understand, because we are getting near the end of the season, so I'm looking at Dave and Megan and I'm saying, what would a reasonable time frame be if KP were to continue talking? Because I know there's other things that have to happen and processes, so what would be?
So thank you, Chair McDermott. I would say from our perspective, our finance team turned around the latest review with, like within 12 hours. And again, that required QA from KP as well. So our team was on standby, Milliman and KP. We turned it around in less than 12 hours. So I think if the board were to ask KP, to take another look at it and respond back either in the affirmative or negative within, 24, 36 hours, I think that's reasonable. And if they were to come back with a new round of rates, we could turn that back around in time for next week's conversations. Dave, does that work with your timing?
Would that be COB?
Or on Wednesday?
Or like noon on Friday?
I would say noon on Friday.
So what does that look like for the board to, like, since I'm fairly new on the board, like, how would that proposal happen if we wanted to do that?
Well, one thing, does the board support that?
I think we should hear from the public first.
That's in the bylaws.
We are going to hear from the public at the end, so we could talk about this after.
My thought is we kind of have to, because otherwise the public will come back and say you had an opportunity to ask and you chose not to. So I'm not speaking for the public, but if I was the public, that's what I would kind of feel like. Why didn't you at least give it a shot?
What I'm hearing
Okay.
generally is a consensus of if there's time, which I said earlier, if we have a little bit of time and Megan just describe the outline, then it seems like the board wants to exercise that ability for another round of possible rates. And so that, we can make sure that we're confirming. I want to think through as we're going through, like, do we need a formal motion, that type of thing. Let me think about that while we still have, half an hour. And also the opportunity for general public comment. And then as we get after public comment, let me just noodle on that, kind of the mechanics of it, because we haven't exercised that the board hasn't exercised that right since passing the resolution in 2020. So let me think about the mechanics of it, but I'm hearing that the board is interested in what those mechanics would look like so you can take that instructive action to be able to solicit another round of rates.
And normally what would happen is we would bring the preliminary rates, we'd bring them one time for the board to see, then at the next meeting we would bring to vote. Doesn't have to be like that. We could just send out the book if there was a rate change, indicate what changed, what didn't, and then come to be prepared to vote. So I think from a technical perspective, we could do it. I don't think the board needs to do a motion or anything. I think the discussion is good enough. It's a self-imposed deadline that we put on ourselves.
Right. Remember the context in which that policy was created by the board was the agency making the recommendation to the PEB board because of a scenario that had happened in the SEB program about, and the scenario was really born out of a lot of concerns from up until, I guess this doesn't exist in the PEB program right now, but up until yesterday morning, if there were other carriers in the portfolio, they haven't seen each other's rates. And so a lot of the concern was, well, there's an unveiling of the rates and then one carrier being able to come in and try to undercut the other carrier in an unsolicited manner. So that was kind of the structural concern that was being addressed by that self-imposed deadline. And so just wanted to remind people of the context of why that exists. So, I guess I agree with you, Chair Whitaker, that there wouldn't have to be a formal motion. There seems to be very clear consensus from board members, both their body language and Monica's words on, and Kurt, I haven't heard anything from you, but so far there's been kind of universal consensus here in the room, and Monica raised her voice.
Yes, absolutely support that.
Okay, since we have so much support, I think we will call it noon on Friday. However, we will listen to the public, and I would be shocked if somebody was like, no, just let it go. You don't have to. We'll listen to the public and see if we have a change of heart, but I think we have consensus among the board. John, I see your
Yes, Mr.
light
Chair,
on.
I'd like to make a suggestion. In so much as it doesn't violate any proprietary information that you have and you're willing to share, I'd like to see what similar sized organizations or approximate sized organizations, what kind of bids they're getting from you, what kind of rates they're getting from you for the year 2024. I know some of them may be multi-year contracts and so forth, but any contract that has specifically been negotiated for 2024 of a size of, 20,000, 15 to 20,000 employees or more. I'd just like to get, if I could, in the board, some idea of what those rates are. And I know we've talked about today why they would be different, but still I think it would be worthwhile for us to look at, see what our competition for employees, what they're paying.
And I do believe you have another slide.
We do.
Okay.
We'll quickly get through the next slide. Here. So really we wanted to talk about the quality and the quality of care at Kaiser Permanente, and that we are committed to the high quality patient-centered care and coverage to our members. And on the left here, there's a few different items that kind of address that our Washington Permanente group actually earned the top ranking for overall quality and cost of care from the Washington Health Alliance in the 2023 report. And I believe we gave you that information at the last meeting. In addition, our Medicare Advantage in Washington plans have ranked 4.5 out of 5 stars. And we have over 90 providers that are considered top doctors in Washington. So we've got an ongoing focus on cost effectiveness, committed to proactive prevention, better treatment and outcomes. In fact, there was a study that actually showed that KP members or Kaiser Permanente members are 33% less likely to experience a premature death from heart disease, and 20% less likely to have a premature death from various forms of cancer, cervical cancer, breast cancer, and colorectal cancer, and that's due to the screenings. It was brought up about the rate increases overall for KP Northwest, so I just wanted to, for the record, put that out there for Kaiser Washington as well. Over the last 3-year period, it was 4.8. So 4.1 for Kaiser Permanente Northwest and 4.8. So we are really looking towards getting back to those as things settle. But total health goes beyond the doctor's office, and so I wanted to address that as well. It goes deep into the communities where we live, where we work, where we play, where we learn. And that's why we have over 5,000 providers practicing in Washington. We also have a research institute, and the research institute is where they're practicing or they're testing vaccines. You've heard the COVID vaccine. We were instrumental in that piece of it. Finding ways to quit smoking and getting that education out. Delaying or preventing Alzheimer's disease, as well as having the HPV testing available at home. So again, these types of discoveries have gone well beyond and helping not only Washingtonians, but worldwide. We also saw the need for making sure that there's more doctors that are having world-class education. And so Kaiser Permanente does have now a school that is in Pasadena, California, in which these particular doctors are being taught person-centered care, quality outcomes, and really having that patient as their partner. We are proud to say that we've had our first graduating class, and those particular doctors went tuition free. So great program that is built there. So other than that, that's the extent of that particular slide. And if there's any other questions, we can take them.
Can I ask how many docs graduated?
Pardon?
How many docs graduated?
You know, I
I thought it was in the 25
I
range. We'll
thought
have
it
to
was,
come
yeah,
back.
we'll come back for
Yeah.
sure, but I was 25.
Congratulations, that's
Yeah.
awesome.
Mhm.
Michaela?
Well, Stacey, you had mentioned earlier around kind of the KP's commitment to equity, diversity, and inclusion. Is there anything that you can share that you all are doing to kind of reduce or mitigate the health disparity gaps?
Yeah, absolutely. Absolutely. Interestingly, the medical school they were talking about is primarily focused on matriculating BIPOC physicians because that's a key component of mismatch, I would say, in our society as being able to have physicians to care for people that have the same culture, race, religion, et cetera. But much of the work, we talked about the Center for Health Research, much of that work is focused on eliminating health disparities. And so a few things that we have done recently or over the past few years, number one, they looked at how to close the gap of colorectal cancer screening for our Hispanic members. So work was done there we have modules that we call Salud en Español, and so work done to reach the population to help explain the importance and to help move that dial. Same hypertension, controlling hypertension in our African American members. So in many of these cases, we have focused on how do you address both the cultural and physical needs, and we've closed the gap in some of the health care disparities. There's another piece of it where we are working on social determinants of health, and we worked with an organization called Unitas, where we have created a social network that helps support members, and we're doing significant screening around houselessness, food insecurity, domestic violence, other factors that we know influence the cost and the ability for people to stay healthy. And so by doing these consistent screenings and putting those into our medical record, we're then determining, okay, how can we connect these individuals to those social services that can help meet those needs. And we've created a way to send kind of like a referral to a physician. You send the referral to those social networks or social organizations. And by so doing, it not only connects the gap so that people can can have that connection, it also helps us understand where the needs are the highest, because as a not-for-profit health system, we have a significant community health and community benefit arm. So it helps us then also drive our own donations and support to those areas of highest need. And so that has been our mission over the past few years, to increase those screenings and to build that network, because it used to be done a lot, as our social workers, they had the Rolodexes, they knew, but there was not a really robust portion where you could have that network. And we've provided that to the entire medical community once built. So our partners and competitors are also able to use that. So those are some examples.
Do we have other questions or comments from the board? All right. I'd really like to thank you for coming today. I know it's difficult, and I'd like to thank the board for keeping it professional but asking the hard questions. It's a tough situation. On a technical matter, if you could let HCA staff know by noon whether something is coming so they can set the machinery up internally to process it, and then by Friday at noon if there's a new bid sheet coming.
Okay.
Just
Is
to
that correct, Megan?
noon tomorrow. I was going to say, I don't think they could tell us in 11 minutes.
Sorry. It's been a long week. It's been a long week.
Tomorrow and noon Friday.
So the just to clarify, the request is that Kaiser give the finance team a heads up by noon on Thursday if something is coming by noon on Friday, and the absolute deadline for that the board is consensus said they would accept another round, and their soliciting bids has a deadline of this Friday.
She even wrote me a note and I messed it up.
Dave, is it either way, is it still possible to vote on these resolutions at the next meeting?
I think we have a path time-wise to be able to proceed with next week's board meeting. I'll assume that if rates come in more favorable than were presented today, that the board would be likely willing to see and act on them at the same time next week, and we can just continue to see how things go over the next couple of days. I will say, board members, you're used to getting your materials on Friday afternoon. That probably isn't going to happen this time, and I'm sure you'll understand why, and it might be Monday morning or Monday midday. We'll just kind of play it by ear and appreciate that.
All right. Any last comments?
Just thank you for your time. Thank you for your patience and your questions. And thanks to HCA. This is not easy for them either. We know a lot of work has been created for the teams as well. So appreciate the partnership and look forward to continuing to serve you. So,
Thank you for coming today. I appreciate it. All right. Next up, we have Shauna Lang, Portfolio Management and Monitoring Section Manager in the PERB Division. Oh, yep. She's here to provide more insight about the procurement process used by the agency for the PEB program. Materials behind tab number 9. Hey, Shauna, welcome. I think you're on mute. Nope.
I think Shauna's gonna probably sign out and come back in.
Oh, there she
That's
goes.
usually the best solution. So we'll just give a minute.
Oh, jeez. Okay. Glad she didn't go down.
And everyone's going to take a quick opportunity to run to the restroom, so we'll make sure Shauna knows that she gave everybody an opportunity. That might have been needed
Why don't
anyway.
we take a 5-minute break then?
Sure.
Okay, we're gonna take 5.
Take 5.
We'll be back, we'll be back at 5 till.
You put us on mute, but as soon as Sean comes back on, let me talk to her for a second.
We'll be back in 2 and 2.
Okay.
2 minutes and 2 seconds.
Let me know when she's in. Okay, and then turn on the mics for a second. Okay, Shauna, we're going on a 5-minute break. People needed a restroom break anyway, so just do the audio check.
You guys hear me?
Yeah, I could hear you. Okay, so we'll be back in a few minutes.
Are we doing wellness or skipping wellness? All right, 11:55. We're gonna regroup here.
Or send me an email or text or whatever. Work today, whichever works out.
I felt bad that Linda brought it here. I was like, no, upstairs. Yeah. Well, I got King County at 1, so I was just like, oh man. Yeah.
All right, we're live.
All right, hey folks, we're back, and Shauna, how's your volume? There we go. We can hear you. Awesome. And Shauna's materials are behind tab number 9.
All right. Good morning, Chair McDermott, and members of the board. My name is Shauna Lang. I'm the section manager for portfolio management and monitoring, and I'm here to talk about the PEBB procurement process. Standard contract timeframes. Procuring for a new benefit or vendor is a significant process, as our contracts outline terms for up to a 10-year commitment. Usually, contracts have an initial 4-year period followed by several renewals. There are exceptions to the periods laid out in the contract, and dates can be pushed out and renewal periods can be adjusted if there are business reasons for doing so. Each procurement takes an enormous amount of work. The time required can vary widely based upon the complexity of the benefit. 18 months would be a typical for a straightforward contract procurement, but that varies. For instance, for procuring life insurance a few years ago, there were fewer moving parts than procuring for a fully insured medical coverage or self-insured medical coverage. The portfolio management team also only has so much bandwidth, so staggering these procurements and not doing several at once works much better for regulating workload within the staff. Procurement considerations. So there are different things that start a procurement. A procurement can be initiated for a number of reasons. For example, an existing contract is expiring or a benefit is changing and we need a new contract. Market changes or vendor performance can also indicate need for a procurement. PEBB doesn't launch a procurement unless there is a real business need to do so, considering all the work and cost required. There are many considerations and footwork that has to go into procurement, including stakeholder engagement, including other governmental stakeholders and HCA internal stakeholders. Other considerations about procurement include the financial, system, and operational needs of a benefit and determining things like performance guarantees, how a vendor will be held accountable for the duration of the contract. Why does it take so long? 18 months is a long time. It's the complexity of staging and executing a procurement that makes it so time-consuming. With benefits and benefit changes, we begin our planning with a go-live date, which is when we want the benefit, this vendor, and the contract to be in place, and then we work backwards from there. 2 to 3 years before we want a procured contract in place, several steps and stages have to be undertaken, starting with the drafting, vetting, and finalizing of an RFP. That process can take up to a year for some benefits or programs. Then the RFP is put out to bid, followed by a review of the bids by the review team, after which an apparent successful bidder is selected. From there, the contract must be negotiated, followed by implementation. We like this period to be at least a year long. These are the activities that organize and operationalize the benefit. Things like setting up the vendor and HCA interface for account management, developing communications, ensuring technical and data systems are aligned. Reporting and so forth must also be aligned.
Shauna, this is Dave. I also, for some reason, just thought of another one that's in here is, depending on the product line, there have to be formal filings with the Office of Insurance Commissioner for a fully insured product. And so those also have their own cyclical annual process timelines. And so sometimes we have to think about the filing process that is necessary for a product to be launched. So didn't think about that every time we prepared this presentation, but it is another factor in there that, again, is another fixed point. We've talked about multiple fixed points. The beginning of January is always January, the plan year. The legislature's in town at certain points. And then for certain products that are regulated by OIC, there's a filing process that also has annual deadline. So just wanted to add that one in.
Thanks. So could a contract go live in January 2025? That's a year and a half. If a decision was made now to issue a procurement, the timeline depicts what best case could look like. Even if pre-implementation phases take the minimum amount of time, implementation itself wouldn't begin until summer of 2024. Just a few months before annual open enrollment, and most everything needs to be nailed down during that time. If there were unforeseen delays in the earlier phases, that would take away from time for implementation. There would be zero room for delays or complications, which could be risky for all the effort involved.
So Sean, I just want to pause for a moment because I just think it's important to say this. We're not saying that 2025 is impossible for anything. We're describing that there are a lot of risks associated with it. And so I just want the board to be aware that, between now and January, as we work on a legislative report, for example, maybe related to retiree benefit offerings, there are stages that we will probably put in place and begin work on different things to keep options available. I don't want anybody to think that decisions will have been made, but we will do what's necessary at the agency to keep options available and keep 2025 opportunities as viable as possible. But I can't sit here today and promise that there are paths to 2025, just like I can't sit here to say there aren't paths towards 2025. It really is depends on a lot of different factors. It's not so I just wanted to say that for everyone.
Dave, can I complicate things a little bit?
Sure, Harry. Go ahead and
try
complicate.
not to, but plan years don't have to be a year.
Plan years do not have to be a year, but there, I want to go back into statute. There are certain things that are fixed like that. Like in the grand scheme of things, you do not have to be on a plan year, but I believe that there are restrictions that would need to be chimed in by. When we say the authorizing environment, that's the broad royal we of state government. It involves OFM, the governor's office, the legislature, the healthcare authority, everybody, collective bargaining process, the insurance commissioner's office. It's the royal everyone. And so there are some guardrails around there, but you're correct. Prior to 1994, the PEB program was not on a calendar year plan. They were on a fiscal year. The health plans ran from July 1st to June 30th. School districts before the SEB program had a variety of different plan years. Some of them were September to August, others were October to September, some were November. Actually, I believe that all 12 versions of non-calendar years existed across the 295 school districts. So, but your point is they don't have to be a plan.
Yeah, and I guess my real point is, understanding the calendar that Sean has laid out.
Mm-hmm.
Conceivably, if the timing was right, something potentially could be done. It's not out of the realm of consideration that something could be done mid-year by extending one plan year or starting a new plan year at a different time, if it was meaningful to do that.
Correct. And as long as there's not a limitation somewhere that also, depending on what that limitation is and how it is, could need changing, and if the stars are aligned and the timing works for those who need to chime in on that are able to chime in. So nothing's really impossible. It's just how long does it take and how much money does it cost to do it. Back to you, Shauna.
All right, thanks. Other factors also impacting how long it takes to execute a procurement is the time required to engage stakeholders, to work through budget processes and legislative schedules. In addition, in the last decade or so, we've seen development of much more rigorous oversight of data management and security, both through the OCIO and the HCA Data Utilization Committee, which determine and oversee security data standards and data sharing. Finally, everything is dependent on ERB maintaining staff of competent and experienced managers to work these procurements. This is an example of a time frame for a relatively straightforward contract for our tax advantage accounts for FSA and DCAP. It's now in the implementation phase. Our current contract, signed in 2013, expires at the end of this year. We issued an RFP more than a year ago and received proposals 2 months later, announced an ASVB 2 months after that. Notice the lengthy contract negotiations. This happened because an essential person was unavailable in the middle of the process. And second, we needed additional time for data security work. These two things took additional time to get the contract signed, and that's why we build longer runways for our procurements. UMP contractual timelines. UMP contractual contracts are longer in term length because of the upfront integration work required between HCA, its third-party administrator, its pharmacy benefit administrator, and in the case of the Accountable Care Program, the network partners and affiliated actuaries. As UMP is the only self-insured plan, it requires the agency to have direct involvement in integration efforts, including customized data feeds, plan management, and setting of premiums. The timeline for the current Accountable Care Plan procurement activities is reflected here overall, a 4-year procurement. In addition, as the current case is, the ACPA could have more potential for more than one apparent successful bidder. This means contract drafting negotiation with up to 2 or more ASBs at the same time. Additionally, concurrent implementation activities would also be with more than one network must be anticipated. Where the ACP procurement currently stands, the RFP was released on June 1st, pre-proposal conference was completed on June 15th, and letters of intent to bid, the deadline closed on June 20th. HCA is now in the process of awaiting bidder questions and then moving into the evaluation period to select the ASB or ASBs, in which that will last through December of 2023. Are there any questions?
I have one, Shauna. On the ACP, it's only been in place like 4 or 5 years, right?
Yes.
So it wasn't a 10-year, 5-year contract with 1-year renewals? Like,
Shauna, the launch of the ACP program was 2016, so we're
7 years.
or is it 2015? Yeah, it's
So, procurement was 2015, go live was 1/1/2016.
well, we haven't had the UMP Plus for them. We
Yeah.
have?
Yeah, we've had UMP Plus since January 1st of 2016.
Time flies
It's
when you're having fun.
I'm 5 years older. Oh, thanks.
Yep. Go ahead, Shauna. No more questions. We're just contemplating time travel here. I think we were done, Chair McDermott.
I do have a question.
Okay, we do have more questions, Shauna.
Tom.
Okay.
So I know this is a hypothetical, but you may have heard we're a little concerned about Medicare bid rates. It's kind of been a question for a while. And one of the members actually suggested a very intriguing proposal, which is because 60% of the costs, the increasing costs of our rates are done because of pharmacy, what if you decoupled pharmacy from uniform medical and made it more like Plan G, where you have to go out and get your own pharmacy rates? So you'd have all of the benefits that currently are with uniform medical except pharmacy. What if that became a focus of the healthcare
authority, what kind of a timeline would you be looking at to bring something like that to the people who are most affected by it, which are the rate holders?
Shauna, do you want me to answer that one?
Go ahead.
Okay. That was me saying I want to answer that one. So Tom, that when I was just previewing, you might hear that the agency is working on different things, but no decision is made. It's kind of directly related to this exact idea.
Okay.
I think it was there was a presentation, I think, on the 29th. That was either Molly's or Ellen's, where we talked about that this idea of either transitioning the UMP pharmacy benefit to a Part D formulary, or the other form of that is a standalone Part D kind of question, has come up a variety of different ways. The small handful of other states that have a coordination benefits type plan that still exists, most of them have a Part D formulary instead of a creditable coverage formulary like we have today. So that was one kind of tea leaf of this is an idea to talk about. It was mentioned in a couple of different ways during some of the listening sessions in March, April, and May. And it actually came up during public comment in June. I forget which meeting it was. And so, that idea in its various iterations has come up in a couple of different ways. And that is one of the areas that the agency is researching, those different options. What we don't know today is how well it fits on a 2025 timeline or a 2026 timeline. So what I was saying a few moments ago about if you hear us working on procurement documents or things, it's not that a decision's made. We would be doing things to make sure that if 2025 is a viable path, that we keep it viable for the board and for the rest of the authorizing environment. So that is an area, that's the exact, it is an area that is being looked at, and we're anticipating describing it in some way, shape, or form in the legislative report that's due December 1st as well. So that is one of the areas that's actively being worked on.
Other questions or concerns? John?
When we discussed decoupling earlier, we also mentioned vision benefits. Okay, that would be another item that would be looked at. Not so much.
Possibly, John, but not as much, because we kind of went through the exercise of vision and decoupling or not decoupling, and it related to some decision packages this last session. So we kind of picked up the vision rock already a little bit. So I don't think that there's a part of it. We're more focused on the idea that has come up multiple times related to the pharmacy piece.
Thank you.
Yep.
Any others? Shauna, thanks so much.
Thank you.
And looking at the clock and conferring with Dave, I think we are going to postpone the Smart Health presentation. Kristen, sorry, I know you were so excited to get in front of the board and tell us, but we want to make sure we have enough time for public comment. So we're gonna punt that to the next board meeting. And Dave's going to go over the 2024 board meeting schedule.
Yes, thank you.
Tab 11.
Thank you, Chair McDermott. I just have one page here. We do a formal filing process, or there's a required formal filing process with the code revisers for public meetings. So I wanted to bring to you, we have not filed it yet because we always bring it to a public meeting first to share with you kind of the approach that's being taken. The board schedule that you see here does lay out the entirety of the possible meetings. I do want to highlight a couple of features that are different than we've done before when publishing a schedule. You'll notice start times but not end times. It turns out that end times are not a legal requirement in these filings, and it just gives us all a little bit more flexibility. I was always a little concerned or just worried that if we had published an end time might be no longer the 1:30 and we went on to 2, what does that mean? So just eliminating that risk. It's not that we're trying to have day-long meetings, it's just it gives more flexibility by not having an end time. But we talk with you and publish agendas a little bit in advance about what that timeline looks like. So you'll just notice start times only. As we get into the July series, we've kept the PEB program on Thursdays. So this year I was very concerned about the switch from Thursday to Wednesday. We'll keep PEB on Thursday. Another feature that we have, and this just relates to managing 2 programs, is for the entirety of the year up until this week, the comparable sub meeting was before PEB, and then we suddenly flipped. And it's just a very hard shift for me, for staff, for everyone to be like, are we going to SEB or PEB next? And we just kind of always do SEB, PEB, and then to switch the other way was confusing for us as well. So it's just trying to normalize that aspect of it. And then you'll also notice that there's 4 meetings in a row that are set for July, and that's just to give us maximum flexibility. Our anticipation is that we would probably only need 2 of those 4, but depending on how rate development is going on, we don't know exactly which 2, and it's easier to schedule regular meetings under the Open Public Meetings Act than it is to cancel them. So you'll see July 11th, 18th, 25th, and August 1st as kind of cresting out. Those are the 4 meetings at the end of the schedule where we would anticipate most likely we'd only need 2 of those 4, which 2 we'd be able to have better tea leaves on in June. But like I said, it's easier to cancel a meeting than it is to schedule them. It's actually a multi-week filing process that you have to beat, or else you're calling a special meeting, and then those are different rules. So it's just easier and gives more flexibility to schedule it this way. But just wanted you to know you should earmark all of them, but we wouldn't anticipate that you would ultimately be meeting 4 weeks in a row. So just wanted to highlight a couple of pieces there. I also wanted to highlight that you'll notice that typically our meetings are like in March, April, and May are in the first 2 weeks of the month, but you'll notice March is a little later than usual because we've thought carefully about what the anticipated end of legislative session will be in a short session. And rather than have a meeting the day that session ends or the day before session ends, we're like, let's just leapfrog past the end of session. So there's a little bit compressed time between the March and April meeting that you're probably not used to. It's usually about 4 weeks apart, but that's a shorter time. Is because we're trying to leapfrog past and be able to give you the comprehensive results of legislative session rather than kind of fourth quarter, 1 minute before the end of the game results of legislative session. So those are just a couple of unique features about this particular schedule compared to past years I wanted to draw your attention to. We plan to file this and then, but you hopefully can go ahead and start marking your calendars.
Any questions or comments for Dave? All right, we're going to do public comment. We're going to collect, if anybody from the public would like to comment, please raise your hand. And we will get that list and try and figure out how much time we have remaining and how many folks we can visit with. All right, looks like we have a small group today, starting with Fred Yancey.
Chair McDermott and members of the committee, my name is Fred Yancey, and I'm representing the benefits side of school administrators and school principals, as well as school retirees. And I clearly understand the struggle you're having with the rate increases because both retirees and actives are and non-Medicare retirees are struggling to meet their medical expenses. And the one testifier, public testifier earlier on a resolution said it quite clearly that a 3% inflation increase, granted to retirees as an example, doesn't even come close to offsetting the increase in medical. So I appreciate the fact that you continue to work on it, but I would politely suggest, and I could be ignorant on this, but I would politely suggest that the board look at the only way to reduce rates is to reduce benefits, in my mind. And so it'd be interesting to see a chart showing if this benefit was taken out, what would be the effect on the rate? If this benefit was taken out, what would be the effect on the rate? That's my 2 cents worth on that. The only other thing I'll add is under the procurement insights, I was a little dismayed to see that the stakeholder input from the public was not presented on the slide at all. She did mention it as a kind of a throwaway, but I think the public needs to be involved prior to the start of a procurement. And they often, the perception the public has is often that they're presented a finished product, without getting in, and then ask for input instead of input prior to that. With that in mind, I'll thank you and let you move on with your day. Thank you for all the work you do.
Thank you, Fred. Sandy Reynolds.
Yes, thank you so much for allowing me this time. So I got United Healthcare this year, and up to this point, it's been really great. My main reason for changing from Kaiser, which I been with for a number of years to UHC was that I could shop for eyeglasses through Costco, which saved me money. This was absolutely a game changer for me when I attended an info meeting that talked about all the benefits of the insurances at the time of open enrollment. I'm at my 24th month, so I am eligible for the Medicare benefit towards my lenses and frames. So I went to Costco and on Sunday and was very excited. We picked out the glasses and did all the work. She went to the process to process my claim, and to my surprise, I wasn't registered with any of the UHC vision plans with Medicare Advantage. So yesterday I spent, not yesterday, but on Monday I spent a good hour on the chat with the UHC agent, and it turns out, yes, I do have vision, but Costco is not a preferred provider because the plan I have to pay part that I have is paid for part as the medical in the medical healthcare plan. So in other words, our plans for UHC do not have an independent vision plan as part of our package, which is what I thought I heard or understood at the time that I enrolled. And I was told by the UHC that if Costco was not willing to bill the medical plan, that I could pay for the full amount up front and then wait to be reimbursed by the medical plan in Utah. Now, the worst part is that I'm in need of glasses, and UHC preferred providers will end up charging me for the frames and lenses. And I think that will be a much, much higher cost to me and more out of pocket than I would have paid if I got them at Costco. So when I was with Kaiser, they applied the Medicare benefit at the time I ordered the glasses. So the bottom line is I clearly remember that we were told that we could purchase our lenses, our glasses through Costco. And I think the point is that during open enrollment, UHC's process was not very transparent, and at least for me, it was misleading. And I wanted to know what HCA could do about that. Thank you.
Thank you so much. Next up, Aruna.
Thank you for a very informative presentation. Aruna Bhuta from Spokane, Washington. And I wanted to bring up a couple of points. One was in terms of open enrollment and the information that the retirees get. I'm an ARPEC member. Sorry, I forgot to mention. The information retirees get clearly doesn't give the benefits of, say, Primera Medigap plan and how it compares to Uniform Medical Plan. There was a lot of information on United Healthcare, but not on the other plans. So it'll be very helpful if at the benefit fairs, we have, in addition to United Healthcare representatives, we would have enough of representatives of Primera Medigap plan. And also too, if Healthcare Authority would provide information in retiree newsletters about the options, alternatives to, UMP and what coverage this provides. That would be very helpful. Secondly, I wanted to know, looking at the denial rates of United Healthcare, are the consumers who are trying to change from one plan to the other plan would be informed about the denial rates, what we have learned about it, in UHC, United Healthcare Complete and Balance, and also to education of the consumers about the appeal process, because appealing is not that easy. Third thing I wanted to make sure was that the Medicare, information, the healthcare information that the providers need to give, within 72 hours. Our healthcare providers and their billing offices are also informed as to how the Medicare Advantage plan offered through PEB, how it is different from the marketplace United Healthcare Medicare Advantage plan. Because when there is no information on that, when the consumer says to the doctor, oh, I have United Healthcare, people would kind of think it is through the marketplace plans, and those two things are not the same. And third question I had was about ACO REACH program, which it says there is alternative payment model. Is that the value-based payment? And what is the administrative cost of ACO REACH and also to the profit margins versus original Medicare, which has the administrative cost of 2.3%? And last question I had was, how is ACO REACH administered by CMS different from ACO, Affordable Care Organization, we have through uniform UMP plus plan that we have for non-retirees and employees? Would like to have some clarity on that. Thank you.
Thank you, Aruna. Linnea, you're up next.
Thank you. Thank you, Chair McDermott and members of the board. I have one, first I was going to defer to Kaiser folks because this is not time sensitive, but I have one comment and one question regarding Ellen's Medicare update. The first is a comment. As a retired RN from UW who did many pre-auths for high dollar medications, here are more reasons why the provider didn't respond in 72 hours, and I am not singling out United. 1, the insurer faxed the PA request late Friday afternoon, even if completed on arrival, received a denial on Monday morning. Many of the insurers are East Coast time. So you start out with a denial, thus delaying care. 2, the insurer didn't accept the prior auth form, which they themselves sent, and it can take hours, including phone tree and wait times, to reach insurers to request the correct form. 3, the provider's chart notes are needed for documentation from the clinic visit when the meds prescribed are often the provider's chart notes, which are needed for documentation from the clinic visit when the medication is prescribed, are not always available on the same day, and you can't submit till you have documentation. So those are just some additional reasons for why a provider's office might not respond in 72 hours. My question is also regarding ACO REACH. This is pages 5 and 6 on Ellen's presentation. Out of curiosity, I checked both the links using my provider and facility. There was no mention of ACO, so I did a live chat with Medicare. The response I got, and I asked about my provider and facility. The response I got was, if your doctor belongs to an accountable care organization known as ACO, they are required to notify you. You will receive a written notice in the mail, via email, or in person when you visit your doctor for your first primary care visit of the year. If your doctor participates in a shared savings program, ACO, there will be a poster at your doctor's office notifying you they have joined. Call or ask your doctor at your next visit if you have any questions or concerns. Then I asked, so there's nowhere on this website that provides this information? And the response was, no, I do apologize. And then I said, will this information be added in the future? And the response was, at this time, Medicare does not have that information. Now, out of curiosity, again, I did look up the two, Northwest Momentum and Peace Health, and Northwest Momentum did say that it was an ACO affiliation. I did not see it on Peace Health, maybe because there's so many parts to Peace Health. So my question is, could HCA find out if there is no ACO designation on the website? Does it mean the provider or healthcare facility is not affiliated with an ACO? Thanks very much.
Thank you. Do we have others? All right. Just a reminder that the board season schedule is posted on the website and is always a part of the briefing books, which are normally posted to the website on Monday before each meeting. Our next meeting.
Oh, I'm
Yes,
sorry.
ma'am.
This is Elliot. In response to Aruna's questions about the 72-hour limitation, can we, when you do respond, can we, as board members, get to see the answers to these questions?
Typically, Elliot, we try to incorporate and do responses in board meetings, even if it's kind of, we look at the public comments and try to think about how to incorporate information into various presentations. So for example, today Ellen talked about COVID vaccine coverage. That was actually a public comment question last meeting. So we are trying to answer things like that and incorporate it into other presentations along the way. So, but yes, if there's something that is outside of a board meeting, but we figure if it's coming up in the public sphere, then we should try to give answers in the public sphere back. So we're trying to incorporate that as we go forward in meetings. So.
All right. Our next meeting is going to be Wednesday, July 19th, starting at 9 a.m. with the same format of attendance in person and via Zoom. And just special note, it is Wednesday, not Thursday. Dave, any final comments?
9 o'clock, not 9:30.
Wednesday at 9 next week.
9 a.m.
Well, we'll see what our full agenda is next week. We may or may not have resolutions for you we anticipate that we will have resolutions for final action on Medicare premiums, and we'll see if there's a difference with the board's solicitation of another round of rates from Kaiser. We will have the Smart Health presentation that we didn't get to today. And then we'll also have some information about open enrollment and that transition as the agency shifts into open enrollment, our communication strategies, and the work that goes along with open enrollment. And then, as usual, I don't think we can have a meeting without Ellen presenting. So Ellen will be back to present something. I'm not sure what, but she will be presenting. I know that much.
She's sitting right behind you, Dave.
Yes. Yes, Ellen always has an encore for sure. So those are the things that I think are happening next week.
All right.
And again, you may or may not get your materials Friday afternoon, like is historically, but we'll get them to you as soon as we can without having to keep sending you multiple versions as well. So.
I just want to thank everybody for today's meeting, board members, your patience through this whole process, staff, all the work that's being done, KP for coming out, really do appreciate it. Good meeting today, and we will see you very soon. Take care. This meeting is adjourned.
Yeah.